Today. Let me be the first to welcome you to the University of Chicago for this spotlight on gastric cancer. This is really a wonderful opportunity to present not only what we have to offer here at the University of Chicago, but the newest in research for inherited gastric cancer. I'm Sonia Kupfer. I'm a gastroenterologist. I lead the Gastrointestinal Cancer Risk and Prevention Clinic here at the University of Chicago. And I wanted to start off the day by thanking people because obviously this takes a lot of effort. First of all, No Stomach for Cancer, and John Florin in particular, who has been, he's right up there, has been really wonderful in organizing this event, and you'll get a chance to meet him throughout the day. Our sponsors, and you'll hear more about that in a moment. I'd like to thank the University of Chicago Comprehensive Cancer Center, who have been co-sponsors for this event. My colleagues, the physicians you'll meet, our nurses, our genetic counselor, who's here as well. I also want to really acknowledge our individuals who will be sharing their stories with you publicly. Obviously, what we're hoping is that throughout the day and throughout the evening, you get a chance to tell your stories to each other. But some brave souls are going to get up here at the podium and share their stories more publicly with you, and I thank them. But most importantly, I thank all of you who have come to this event. You're coming here for probably a variety of reasons. You're in different stages. Your patients yourselves, your family members, your caretakers, your supporters, your doctors, your healthcare providers, but this is really about you, and so we want to make this as interactive as possible. If you don't feel comfortable asking questions during the sessions, we're going to be around here. Just find us and ask us any question that you have. And so I just wanted to briefly talk about our center, just sort of to lay the groundwork here. So William Osler is one of the great physicians in American medicine, and he once said, a good physician treats the disease, the great physician treats the patient who has the disease. And I think what we're learning more and more is that obviously medicine has become not just one doctor, but really a team approach. So I took the liberty to change it a little bit to say the good center treats the disease, the great center treats the patient and family who has the disease. And so that's really a guiding principle for us here at the University of Chicago. I'm sure as patients or family members, this is sometimes how you feel. You feel like, okay, you need to go see this person, that person, this person, that person. They're on floor 6, 5, 2, 3, and you go on 5 different days. And so, obviously fragmentation is disruptive for everybody, including the healthcare provider, but more importantly for patients and their family members. So there's this concept of a center of excellence, and that can be defined as a program that's within a healthcare institution that is there to provide exceptionally high concentration of expertise, related resources centered on a particular area of medicine, and deliver associated care in a comprehensive and interdisciplinary fashion. And really the most important thing here is the patient outcome. And that is defined in a lot of different ways, but that's really the goal here. There was a nice publication by Dr. Davis, who's here, and some of his colleagues, as well as some patient advocates, about specifically establishing centers of care for hereditary diffuse gastric cancer. And they really define some key components, and I think these are really a guiding, sort of a roadmap for what all of us who provide care for patients with inherited gastric cancer should be thinking about. And so this will include genetics and genetic counseling, gastroenterology, nutrition, surgical oncology, pathology, breast oncology, psychosocial support, research, and community engagement. I'm happy to say that we have that here, and our mission has been that from the beginning, to provide multidisciplinary team approach for personalized medicine for early detection, prevention, education, and research. So just to introduce you a little bit, and you'll be meeting all of these people throughout the day, we really put the patient and the family in the center. So I made this more of a circular rather than a hierarchy. We are the entry point, so that's myself and Jessica Stoll, who is our genetic counselor, and we like to think of ourselves as the co-captains with the patient, at least at the beginning, so that we can help to manage where everybody needs to go and when. Then we have, very importantly, our surgeon, Dr. Kevin Rogan, who's sitting up in the back there, and our GI nutrition physician, Dr. Semrad, who will be here a little later this morning. Really key individuals who take over the care for a certain period of time and are really critical in our mission here. And then also our pathologist, Dr. Namrata Setia, who you'll meet. And then for those women who are getting breast cancer surveillance, we have Dr. Sheth, who's also sitting up in the back, and you'll meet her to help guide women for their surveillance if they choose to do that. We also have a registry, so this is just a screenshot of what that looks like. Basically, this is our database where when patients voluntarily approve to be part of this, we put information in here so that we can learn more about hereditary diffuse gastric cancer and inherited GI cancer syndromes in general. And basically what we have here is information about screening procedures, surgical procedures, pathology, etc. So we have a flyer out at the desk. If you're interested in participating in our registry, please pick that up, and there's information there on how to do that. Community engagement is critical, and so we're very grateful for No Stomach for Cancer, who make this very easy to get all of this out to individuals who either have come here before, but also to a broader community. Also, we perform research, and we're very interested to learn more and do better. So there is a survey on the table right over here. If you haven't had a chance to pick that up, it is, again, completely voluntary and anonymous, but this will help us to understand what brought you here today, what your background is, and then more importantly, what the unmet needs are in treatment of hereditary gastric cancer. And that will help us to design a much bigger survey that we're working on with patient advocates that we hope will go worldwide so that we really have a good understanding and that your voices are heard kind of in unison and internationally. The agenda, you have it here. I'm not going to go through it in detail, and we'll really be covering all of the bases here. I do want to just mention that at 5:30 there is a reception in the Quadrangle Club, which is here on the campus on 57th Street, just a little bit east of here. This is really when the fun happens. This should be fun too, but that's really where you can just in a relaxed environment continue those conversations, that interaction. And then I just wanted to end before I introduce the board chair of No Stomach for Cancer, who's going to do a short introduction. I had the really good fortune of attending the International Hereditary Diffuse Gastric Cancer meeting in New Zealand this year. This is where the guidelines are written, and was a phenomenal opportunity to interact with people who are really dedicated to making care and screening and surgery and everything better in HDGC. And I happened to go to the Auckland Art Gallery, and I found this painting on the wall. And the story behind it isn't really that important. It basically says 1968. It was an important year in this artist's life. But importantly are the two animals that you see there. Does anyone know why I'm putting it up here? Seahorses don't have stomachs, or teeth for that matter, I learned. But I think just to remind us that you can live without a stomach, you can thrive without a stomach, and you can flourish without a stomach. And so hopefully at the end of this day, we will have made an impact in your lives. So with that, I thank you, and I'm going to now turn it over to Roger Byers, who is the board chair of No Stomach for Cancer. He's going to do a short 5-minute introduction, and then we'll dive right in. Thanks.
5 minutes, you've never heard me talk, have you? Good morning. A lot of familiar faces out there. A lot of you have been to these before. I always like to start, who doesn't have a stomach? Look at all. And they say you can't live without a stomach. My name is Roger Byers. I am the board chair of No Stomach for Cancer. We are headquartered in Madison, Wisconsin. When I say the word headquartered, that you picture this big, massive building. No, we are totally not that. We are really a grassroots organization, and we are very pleased. This year, we're celebrating our 10th anniversary. That's cool. And this is also the 10-year anniversary when we got the United States Senate to authorize officially November as Stomach Cancer Awareness Month. So those are all great and wonderful things. It does take a lot of effort, as you know and everyone knows, to put on one of these events. So we, again, want to express our thanks to the university. But it also takes resources to put these on. That's why I wanted to mention our specific sponsors who have been with us, and without them, we could not do this. We simply could not do this. Lilly Oncology, Astellas, Daiki Sakio, I had fun with that one, Taiho, and DeBio Pharma Group. So they make this possible for us. I would also just like to say that last month we hit a milestone. I remember years ago when we did our first $10,000 grant. We thought that was so cool. Last month we approved our biggest grant in the amount of $230,000. Now that ain't bad for a little organization that only has one paid employee. That is not bad at all. Our money comes from walks and worldwide walks. So we're proud of that. I would very quickly just like to point out two people that, Cheryl and Yi, they're actually, because this ends at 2:30, they're looking for some volunteers who might just want to sit down and chat with them, get some information. Cheryl is looking for people who are CDH1 positive, whether they've had a TG or may be looking at one. And Yi is looking for people who are, again, CDH1 positive, have not had a total gastrectomy, and are somewhere around 30 years of age. So if you'd like to do a little time at the end of the program, sit down, chat with them, they could really help them out. So with that, oh, by the way, I got one little tiny thing to do. I promised John I wouldn't embarrass him today. I said, John, I will not get up in front of a crowd of people and tell everybody that's your birthday. So just forget that I said that, okay? So I'm going to send it back down to Dr. Kupfer, and let's get started. So thanks again for coming, folks.
All right. So I'm going to kick things off with an overview to set the stage. Let me just open the right one. You don't want me giving the surgery lecture. That would be a disaster. Okay. So I'm going to set the stage for what we're talking about, and I'm sure that many of you are very familiar with this. Some of you might not be, so I just want to make sure that we start at the beginning. And the questions really are, what are the inherited stomach cancer syndromes? And then more specifically, what is hereditary diffuse gastric cancer? Or you'll hear it referred to a lot, HDGC. So let's just start to remind ourselves what we're talking about. We're talking about the stomach. And so the stomach is a part of the digestive system, and it, as you can see here, is hiding out behind the liver. The stomach, sometimes we refer to it in its individual parts. Of course, these are all part of one organ, but here we have the esophagus, and then you may have heard, if anyone has undergone an endoscopy or even your own surgery, different parts of the stomach that we talk about. And I just want to say this because this will keep coming up throughout the day. So there's a part here that we refer to as the cardia, the fundus, the body, which is the bigger part here, the antrum, and then the pylorus, which is the entry point into the small intestine, which is called the duodenum. So if we then go even further, dig down even further into the stomach, if we were to take a section of the stomach out and look at it under the microscope, this is what it would look like. And there's just a few terms I wanted to talk about here, because again, this is vocabulary that will come up throughout the day. So we have the mucosa here, which is the innermost lining, and we have a lining here that some people may refer to as the epithelium, and there are cells that are together here, and they also form these long glands or crypts. We then have a supporting area here called the submucosa, some muscle layers here because of course the stomach needs to churn all that food, and then we have a lining here on the outside called the serosa. If we were to turn that around and look at it under the microscope, this is something our pathologist, Dr. Setia, does day in, day out. This is what it would look like. So this is a piece of stomach that has been mounted into basically wax, and then very thin slices are cut, and they're stained so that we can see the different elements. And so if you think about this lining here, this epithelium, you can see you can get a sense of what you're looking at here, and those cells that are nicely right next to each other, and then these large glands here. All right, so we've now established, we're talking about the stomach. We've looked at the different parts of the stomach, and then also what the pathologist will look at. And Dr. Setia will go through even more images and pictures, but hopefully that gives you an initial idea. Gastric cancer can be, or is traditionally broken down into two different types. As we're learning more about gastric cancer, it actually becomes much more complex than this, and this is really what we sort of refer to make it easy, but just so you know, there are other ways of classifying gastric cancer. But broadly speaking, there's an intestinal type and a diffuse type. So if we look at the intestinal type, there is thought to be this stepwise progression from a normal lining here, and here we're talking about that lining, that epithelial lining that is on the inside of the stomach. Then it's thought that there's some kind of inflammation. So for example, this could be in the case of a bacteria called H. pylori that can lead to inflammation. That then leads to a change in the lining. It kind of alters itself to be more like the intestine, so that's a next step. Then we have a change to more cancerous, precancerous type changes, and then ultimately to cancer, where basically the cancer cells start invading into the lining of the stomach. If we contrast that with the diffuse type, here it's almost going from normal to cancer. There are some steps in between, and I'll show you some pictures of that, but we don't think that there is sort of this very exact stepwise progression. Or it may be that there are cancer cells that are sort of sitting there in that lining or right underneath that lining, and at some point they have an advantage to start going into the lining of the stomach. Still a lot of things that we don't understand about this process, but just to give you a contrast in terms of the types of stomach cancer. So I'm sorry to have to bring these endoscopic pictures. This is what I look at day in, day out. So this is looking at the stomach, and this is what an intestinal type of stomach cancer might look like. I hope you can see that it's this sort of raised area here. It's visible to the eye. It's something that someone could go in there and look at and say, yeah, there's something abnormal there. This is another image where there may be ulceration and sort of it heaps up on the sides of those ulcers, and this is what intestinal type of cancer would look like. Contrast that to diffuse gastric cancer, which is really, really hard to detect with a scope. So I'm showing you some images here, and it may be not so easy to appreciate that you have all of these folds in the stomach. And again, the stomach is like a balloon, and when the food comes in, it needs to sort of be able to accommodate that food. Well, I've basically pumped all the air that I can into the stomach, and it's just not inflating like a balloon. It just sort of sits there, and the folds are very, very prominent. This is because there are cancer cells that have infiltrated into the stomach, and it just doesn't have what we call distensibility. It doesn't have that balloon-like quality to it anymore. The other thing that we can see, and I've put these arrows in here because it can be very subtle, are these very pale areas. So just to remind you, this is the fundus. So you remember that when I showed you the picture of geographically where we're located, this is actually the scope. We're turned around looking back at the scope. So this is the fundus. This is more of the body or transition zone here, and you can hopefully see these very subtle pale areas. This is where I've switched on a different light filter called narrowband imaging, and that may or may not may highlight these areas even more. And this is where the diffuse gastric cancer is. So you can imagine how difficult it is to identify cancer early in diffuse type gastric cancer. So if we were to look under the microscope, and Dr. Setia will provide more images, so I'm not a pathologist, so I don't want to pretend to be one, but even under the microscope, there are obvious differences. So the intestinal type of gastric cancer is still trying to form glands. It's basically, as I mentioned, it has these changes. It's like the intestine. It starts to look more like the intestine. Whereas diffuse type gastric cancer is just these small cells that have kind of made their way into the lining of the stomach. So even under the microscope, of course, we can see differences. All right, so one of the questions that I was asked to address is the hereditary syndromes that involve the stomach or stomach cancer. So we can broadly characterize these as ones that predispose to more of an intestinal type of cancer and then the diffuse type. So there's a lot of different acronyms here, and I'll take you through these, but I'm not sure how many individuals here are affected by one of these, but there are individuals who have what we call familial gastric cancer. So that's where we may not find a genetic mutation, but they have a clustering of individuals in their family who have had gastric cancer. And in fact, this can be the intestinal type, but it also can affect people who have diffuse type. There are syndromes where people develop a lot of polyps in the gastrointestinal tract, and those can involve the stomach, and that's this syndrome called GAPS. They can involve the stomach and the colon. That's this syndrome called familial adenomatous polyposis. They can be different types of polyps called hamartomas, and that can be in the form of a syndrome known as juvenile polyposis or Peutz-Jeghers. They can be a problem in how the DNA repairs itself and leads to a syndrome called Lynch syndrome, which is predominantly colorectal and endometrial cancer, but can involve a risk of stomach cancer. There are other genes that may be involved, and maybe you've heard of some of these. So breast and ovarian cancer syndrome, and those genes are called BRCA1 and 2. Those can also predispose to gastric cancer, although it's not a predominant cancer in these syndromes. Other genes like PALB2 and ATM, and then finally a master regulator gene called TP53 that can also lead to gastric cancer. Turning to the diffuse type, this is where hereditary diffuse gastric cancer is the main syndrome. It accounts for a very small percentage of all gastric cancer, but obviously has important ramifications, as many of you know. The predominant gene that has been identified is called CDH1, and I'll just briefly touch on that. There's another gene called CTNNA1, and this has been discovered more recently as a cause for some individuals who meet criteria for diffuse type hereditary gastric cancer. And then there's a lot that we don't know, and we still have to continue to do research to understand in those families where there's clustering of diffuse type of gastric cancer, what's going on there. And there may be overlap too. So there are studies that show, for example, that BRCA patients may actually develop a diffuse gastric cancer, although predominantly they'll have that intestinal type. So just, I still have some time. So I just wanted to talk a little bit about CDH1 because my other question was to talk about HDGC. So I'm just zooming in here on that lining of the stomach, and you can hopefully appreciate that there are these nice, long cells in that immediate lining there, and these purple areas here, those are called the nuclei. And so this is a very regular appearance, and the cells need to know how to stay in that regular appearance, like little soldiers right next to each other. And it's a very complicated, complex reason that that happens, but one of the main things is E-cadherin, CDH1. CDH1 is the gene, and what the gene makes is something called E-cadherin. So if we took that image there, and if you could now sort of look at this cartoon, and now we're looking at each of those individual cells. So we have the nucleus here, and inside there's a whole big system that keeps those cells where they need to be. It keeps them stuck to each other or adhered to each other. And it also tells it what's the inside of the stomach and what's the other side of the stomach. So it helps to figure out what we call polarity. And there's this complex called the adherens junctions here. So you can see that these are kind of like the bits that keep the cells together. And then if we look at that, this is more even of a cartoon. So we have the cells here, and then you have this cadherin molecule here that essentially is keeping those cells kind of in check where they need to be. So you can imagine if you lose that function, those cells might start to not really know where they're supposed to be, and they don't know what's up and what's down. And so that's, in a simplified form, what is thought to be going on in this syndrome. Of course, it's much more complex, and I don't even understand some of that complexity because these cadherin molecules may have even more functions, and they do. But that's the basic understanding that we have of what's going on. So how did we identify that CDH1, that gene, was responsible for this syndrome? And this is a very important person. Does anyone know who this is? Perry Guilford, yeah. So this was at that New Zealand meeting that I mentioned, and this was at a wonderful dinner at a winery, and he's actually, you can't see it, but he's wearing a tie with seahorses on it. So that seahorse theme will continue to come up. But Perry really was the one who, through looking at a large family of the native population of New Zealand called the Maori, was able to sort of figure out where in the genome the problem was, basically. He used something called linkage to identify where the gene was. And you can see here, this was the publication in 1998. Now, I remember 1998, so this is not something that is like, ancient history. This is still, this is happening in our lifetime. So we're, very grateful to Perry and his colleagues, obviously, who really started, gave us the ability now to test for this gene in family members so we could figure out early on, hopefully, who had the gene and then could do something about it. So this was really groundbreaking, important research. And one of the things that was discussed at this meeting, and it hasn't been decided, but there was some thought about maybe we should be honoring the individuals who really set us on this path when thinking about this syndrome. So more to come on that, just a slight preview there. So what's happening in diffuse gastric cancer? So remember, we have this normal lining here. And what's thought to happen is that these cells, remember, they're losing their sort of direction, and they don't know where they're supposed to be, and they start to form these little cells that are kind of they sit underneath the lining of the normal stomach. And their cells also start to look kind of funky, and they are referred to as signet ring cells. So if you know what a signet ring is, basically it pushes the nucleus, that purple thing, to the side and is a very rounded kind of structure. And those start to sort of hang out around here. It's called a pagetoid spread of these signet rings. And then at some point, and this is obviously, we're trying to get to this before this happens, those cells, those abnormal signet ring cells, start to make their way down into the lining. They don't go up. They don't form what you saw with the intestinal type, any sort of mass or any sort of ulcer. And it's thought that those sort of very subtle things, like the thickened folds and those pale areas, may represent where these abnormal cells are kind of hanging out underneath that lining. Here's another cartoon, so you can see the normal lining here. You start to have accumulation of those abnormal signet rings underneath. They haven't really done anything. They're just hanging out. And then at some point, they get some advantage that starts them on their trek downward. And it's here where we start to see the spread, and then we have more advanced cancer. So hereditary diffuse gastric cancer has very specific criteria, how we sort of determine who might be eligible for testing or should be considered for testing. I'm going to go through these quickly. So 2 or more documented cases of gastric cancer at any age in first and second degree relatives, and 1 needs to be a confirmed diffuse gastric cancer, or someone who had diffuse gastric cancer before the age of 40, or someone with a personal or family history, that means a first or second degree relative, of diffuse gastric cancer and lobular breast cancer, and one needs to be diagnosed before the age of 50. So you can see that we really still don't exactly know, how to capture all of the individuals who have HDGC, but this is one step where we can apply these criteria to decide. There are also some supporting criteria, so these are things that can help broaden that net so we can catch more people. That includes people with bilateral or multiple cases of lobular breast cancer before the age of 50. So some individuals who have HDGC actually don't even have any GC in their family. They have mostly lobular breast cancer. And this is why at the meeting this March, there was a discussion about maybe the name of the syndrome should actually reflect the heterogeneity, the different kinds of ways in which these families present. But more on that hopefully to come. Also, individuals who have a clustering of diffuse gastric cancer and cleft lip or cleft palate, this is an association with CDH1 mutations. And then any patient who's diagnosed with in situ, that means those signet ring cells that are kind of just sitting there under the lining, or who have that particular type of spreading pattern called pagetoid spread. I'm here to tell you that not everybody fits that criteria. So if you're looking at those and you're like, wait a second, my family is not in that category. We're learning much more about this, and this will help to inform our criteria. But Jessica's probably going to mention some of this, but the way in which we do genetic testing, this has changed dramatically over the last 5 or 8 years. We don't just test one gene necessarily. Now we're testing 10 genes, 15 genes, 40 genes. I think the biggest one is 80 now. So 80 genes all at once for mutations. And so what we're finding is CDH1 shows up on almost all of these panels, and we're finding individuals who are tested because they have colon polyps, and then they're found to have a CDH1 mutation, and they look at their family and say, nobody has had gastric cancer, no one's had lobular breast cancer, where is this coming from, and what do I do with that? And so it's opening up a whole new area of what is the risk in a family that doesn't have a lot of people with gastric cancer. And I think we don't quite have that answer yet, but at this point, we are still managing everyone with the CDH1 mutation in the same way. So the key points, overall about 5 to 10% of gastric cancer is hereditary. Now, HDGC accounts for a very small percentage of gastric cancer overall, probably even less than 1%. And hereditary syndromes can lead to different types of cancer. So broadly speaking, we have the intestinal and the diffuse type. HDGC is due to mutations in CDH1, and the CDH1 gene makes a protein called E-cadherin, which is responsible for that adhesion of cells within the stomach, and by the way, also the breast, and Dr. Sheth will talk about that. And diffuse gastric cancer, importantly, develops under what, for every tool that we have, although we're getting better with our tools at finding things, but for all intents and purposes looks relatively normal, and that leads to a lot of the problems and difficulties that we have with surveillance in this syndrome. So I want to thank you for that. That was the introduction, and I'm going to turn it over now to Jessica Stoll, who is going to be talking about genetic testing. Jessica is a cancer genetic counselor. She's specifically focused on GI cancer syndromes and works side by side with me. As I mentioned, we are the entry point for our gastric cancer clinic here. So our information is sort of everywhere out there on flyers, and my cards are here as well. So please feel free to reach out to either of us. Jessica is originally from Southern California, but she did her training here at Northwestern and has stuck around in Chicago, and she is phenomenal. If anyone, and I know some of you in here have had counseling by her, I come in and everybody says, I have no more questions. She's done an amazing job, so I know that you will learn a lot from her in the next half hour. So thanks, Jessica. You have your...
Well, thank you for that introduction. I learned from the best, so we have very much a team approach here. And what's funny about that is without running our slides by each other at all, I feel like we're going to mimic each other quite a bit today. So I've kept my slides relatively short today because I wanted to make sure I left time for questions. I feel like a lot of the times when I'm meeting with patients, it's less me giving information and more just answering the questions you already come with. So I wanted to make sure we had time to do that today. But as Dr. Kupfer mentioned, I am a genetic counselor. I do specialize in hereditary cancer syndromes, in particular gastrointestinal syndromes. But today I wanted to talk a little bit more about the basics of genetic testing. I know, like Dr. Kupfer said, a lot of you have maybe had genetic testing, but others may not have gone through that counseling process. And so I wanted to give you sort of a general overview of what genetic testing looks like. We'll touch a little bit on the genetics of hereditary gastric cancer, although Dr. Kupfer gave you a great overview already, so we'll fly through a little bit of that. And then I did want to focus a little bit more on our approach to genetic testing for hereditary gastric cancer. Genetic testing really has changed very dramatically since 1998 when Dr. Guilford discovered the CDH1 gene. It's really even changed quite a bit since I started practicing 5 years ago. So things have shifted rapidly, but it's definitely not a one-size-fits-all approach, and so we'll talk a little bit about that. And then I really wanted to touch on interpretation of genetic testing results, because that I think can be a really tricky sort of thing to navigate as a patient. Even as a genetic counselor, it's sometimes tricky to navigate. I also want to keep this interactive, so if anyone has any questions throughout, please interrupt me. I'd rather answer them up front than wait till the end and have someone forget a question. So basics of genetic testing. This is my bread and butter. This is what I talk about day in and day out with my patients. But this picture is just to depict that genetic testing can actually be done on a number of different specimens. So for those of you who have had genetic testing, I imagine a lot of you did a blood draw. There's a couple of reasons for that. The primary one being that we have a lot of blood. It's pretty easy to get enough blood to do genetic testing, and it doesn't actually take that much blood to extract the DNA that we need to look at. Sometimes we're able to do a saliva sample in our clinics. I prefer not to do that in my clinic. It takes a lot of saliva, and if any of you have done a saliva kit, you have to sit there for a long time and spit into a tube, and it's not the most pleasant process. So for children, though, sometimes that is a helpful option if I need to test kids in my clinic. And that Petri dish you see there is for patients that have what we call hematologic malignancies or blood cancers, so things like leukemias and lymphomas. This doesn't necessarily apply to hereditary diffuse gastric cancer, for example, but there are some syndromes where patients will have leukemia, and unfortunately their blood is the tumor, so we're not able to run genetic testing on their blood. And in those cases, we might have to actually do a tiny little skin biopsy and sort of culture the skin cells to extract DNA from there. But very generally, genetic testing is a way for us to read through genes to look to see, are there any spelling mistakes, any large pieces missing, anything that's causing a gene to not function properly. And that's not necessarily just for hereditary cancer, that's for any genetic condition, but it's a way for us to diagnose a patient with the condition, to learn what sort of treatment they might need, what sort of screening they might need, and it allows us to determine if family members might also be at risk for these conditions, because when we're talking about genetics, we're not just talking about the patient, we're talking about the family as well. So some benefits of genetic testing. In the case of, I'm going to focus now shifting more towards hereditary cancer syndromes, this really can provide a more specific cancer risk for our families. I feel like a lot of families come to see me and they say, oh, cancer just runs in my family. It's just everywhere. It's always been that way. You know, I'm just going to get cancer because I know the family has cancer. But if we're able to determine if there's a genetic cause for the cancer, we're able to determine what specific types of cancer they might be at risk for, what the degree of that risk would be, and who in the family may not actually be at risk of developing cancer. So I think that's just as important. In some cases, kind of going along that same thought process, it might provide an answer for some of our families. So these families that have just had cancer throughout the decades, over the generations, they've never actually determined why. There's always, you know, some superstition about what's going on in the family, but at the end of the day, the genetics might be the answer for that family. In the case that we're able to identify a genetic cause for the cancer, we may have the capability of decreasing cancer anxiety if we're able to determine that a family member doesn't have that genetic mutation. So that's where genetic testing can help not only provide an answer for if they are going to be at an increased risk, but those who are not at increased risk as well. And that's sort of where it can have an impact on family members. While we're testing a patient who's sitting in front of us, it ultimately has the ability to provide information for family members across the board. Now, I don't want to pretend that there aren't some limitations of genetic testing as well. And I put the word risk up there, but I think limitation is a better way of putting this. We're going to touch a little bit more on interpretation of test results. This is really, genetics is not black and white. In fact, in my mind, genetics is one big gray area. And so it's really important to be able to interpret those very carefully. I put up on the last slide that this has impact on family members. That sometimes is a limitation in some families, and maybe that's a risk that they feel like, now I have to talk to the rest of my family about this. So I think it's sort of a benefit and a limitation there. Cost and insurance coverage used to be more of an issue. I'd say back in 1998, it was definitely more of an issue, but nowadays we're getting away from this sort of cost, the cost restrictions and the insurance coverage issues. Actually, a lot of insurance companies are covering genetic testing now if patients are meeting the criteria for testing. And for those whose insurance won't cover testing for whatever reason, the genetic testing companies are really making a strong effort to bring the cost of this testing down. And I can get that 80 gene panel that Dr. Kupfer was talking about, I can get for $250 for my patients out of pocket. So we're really making this less of a limitation or less of a limiting factor for our patients nowadays. Now, of course, knowing that someone has a gene mutation might result in an increase in anxiety. I always like to frame this as this is our opportunity to help prevent cancer, help detect it at an early treatable stage, but of course we recognize that knowing this information might cause a little bit of anxiety for some patients and families. And then I do get a lot of questions, especially in the last couple of years, about concerns about genetic discrimination. And so I did want to touch a little bit more specifically on that today. Has anyone heard of the Genetic Information Non-Discrimination Act, or GINA? A few. Okay, good. That's good. Well, now you'll hear more about it, because I think this is a really important act. And actually, we're coming up on the 10-year anniversary of GINA as well. It's 10-year anniversary for a lot of different things. So the Genetic Information Non-Discrimination Act was originally passed in 2008, fully put into law in 2009, but it prohibits discrimination by health insurance companies and employers based on genetic information. Now, genetic information refers to a patient's genetic testing results, family members' genetic testing results, and family history of disease. So I think that's important to recognize that includes all of that. What that does not include is life insurance, long-term disability insurance, and long-term care insurance. So I think those are a couple of different caveats that we want to keep in mind when we're talking about GINA. This really only applies to health insurance companies and employers. Now, that is on a federal level. On a state-by-state level, there are individual laws. And in Illinois, I can say that we just changed our name. The Illinois Society of Genetic Professionals is working to pass an act that will actually allow GINA in the state of Illinois to apply to life insurance as well. So this does vary state by state. Stay tuned to see what Illinois is going to be like. I can't speak to all 50 states at this point, but just know that there are some individual state-by-state differences as well. Any questions on that? I feel like this is one I get a lot of questions about, so I want to make sure I stop real quick. Yeah?
Do you advise your patients to go ahead and get life insurance and those type of things wrapped up before you do the testing?
That's a great question. I usually tell my patients that this is somewhat of a theoretical risk, that GINA does not cover life insurance, so I can't say that those protections are there. I have not had a patient come back to me and say, I was unable to get life insurance because I had genetic testing. But for those who have those concerns, I usually say, work on getting that policy in place and then come back and see me when you've got that in place, and we'll do the testing at that point. More of a safeguard than anything else. It's a great question. Yeah. That's great. Thank you so much for sharing that. That's really helpful information. I feel like we get a lot of questions about that when the kids are starting to come back for testing. And so knowing that, even we can take out a policy for an 18-year-old and it's as inexpensive as $20 is really helpful to know. Thank you so much. All right, well, we'll move on from the fun stuff and focus a little bit more on genetics and genetic testing. So Dr. Kupfer has already talked a little bit about this, but as far as hereditary gastric cancer goes, we really break it into intestinal and diffuse type. And so she's done a really good job at laying this out. I wanted to give an introduction a little bit to the genes themselves. Now, this sounds like alphabet soup, so there will not be a test at the end of today, but Lynch syndrome, as she was mentioning, is a problem with repair of DNA. There are actually 5 different genes that cause Lynch syndrome. The risk of gastric cancer with Lynch syndrome is relatively low in the grand scheme of things. Like she was saying, the risks are primarily for colon and endometrial cancer, with some other cancers that have an increased risk as well. We talked a little bit about polyposis syndromes already, familial adenomatous polyposis, or FAP, the APC gene, and then a slightly different condition, but presents similarly, is due to the MUT-YH gene. We also talked about juvenile polyposis syndrome, which is caused by mutations in either the SMAD4 or BMPR1A gene. Now, those genes typically present, or those syndromes, I should say, typically present with polyposis throughout the GI tract, so in the colon, and then we sometimes see polyps in the stomach as well, but they both carry a slightly increased risk for that intestinal type gastric cancer. And then, as we discussed before, the hereditary breast and ovarian cancer syndrome, that's caused by BRCA1 and BRCA2 mutations. The primary features of that condition include breast and ovarian cancer, but we have seen some data to suggest there's an increased risk for this intestinal gastric cancer as well. And then Dr. Kupfer mentioned a couple of other genes, PALB2, ATM, and TP53. I think this slide is really just to show that there are lots of different genes that can cause gastric cancer. It really is not just 1 or even 2 genes. And so that's something that we'll touch a little bit more on when we talk about our approach to genetic testing. I'll fly through this because Dr. Kupfer gave a wonderful overview of HDGC already. Now, CDH1 mutations, I'm sure many of you are familiar with. They actually only account for about 30 to 50% of families that meet that criteria that Dr. Kupfer spelled out. So someone can have a diagnosis, or a family, I should say, can have a diagnosis of HDGC, but not ultimately have a CDH1 mutation. On the flip side of that, as she mentioned, some people have CDH1 mutations and don't meet that HDGC criteria. So it's sort of a world that we're still trying to learn a little bit more about. Now, for some of those families that meet HDGC criteria that don't have CDH1 mutations, we have identified CTNNA1 mutations. This is a very new gene. We only recently started being able to test for it in the United States, and there have really ultimately only been a couple of families that have been identified with these mutations. So at this point, the exact risks are a little bit unknown in comparison to CDH1, but there is a lot of active research going on with CTNNA1 to try and define those risks a little bit more. All right, so it's a good transition into our approach to genetic testing. I mentioned before that genetic testing is not one size fits all, and that's partly because of the number of genes that can cause things like inherited gastric cancer. Has anyone seen a family history drawn out this way? Okay, a few of you. So for those of you who have seen a genetic counselor, I hope they've shown you your family history drawn out this way, because this is what I look at day in and day out, is family histories like this. This is what we call a pedigree. And I want to see if I can, I don't know if I have oh, here we go, a cursor here. So I wanted to just point out a couple of things here. So as far as what this diagram is looking at, circles are for women, squares are for men, lines connect relationships. So these would be siblings here, these would be parents, and then grandparents on either side of the family. Anyone who has any shading in their icon just indicates a cancer diagnosis of some type. So in this family, you can see my patient here, who's indicated by the arrow, has a diagnosis of gastric cancer at age 40. Her father had gastric cancer at age 60. His sister, so my patient's paternal aunt, had breast cancer at 50, and then her paternal grandfather had gastric cancer at 35. Is this looking familiar to any families here? Is this something that you've seen in your family? Okay. Now, on the other side of this family, what I want to point out is, well, this is all on my patient's dad's side of the family, right? It's just clustering on one side. But on her mom's side of the family, there's a colon cancer in her uncle at age 40. There's also a uterine cancer in her maternal grandmother at age 50. So that's on the opposite side of the family from all of the gastric and breast cancer. And I wanted to point this out because when we're talking about genetic testing, it's a little bit difficult for us to pinpoint one single gene that would cover both the paternal side of the family, the father side, all of his cancer, keeping in mind that there is a maternal family history. We have to always keep in mind both mom and dad's side when we're thinking about genetics. Now, in this case, my patient who's sitting in front of me, she has a diagnosis of gastric cancer. Yes, CDH1 is very high on my list of genes that I'm worried about, just given her dad's side of the family. However, her mom's side of the family is actually more suspicious for that condition, Lynch syndrome, that we were talking about. So in this case, this would be a situation where I would not just test one single gene. I wouldn't just offer CDH1 gene testing. I would do what's called a gene panel approach. Has anyone had gene panel testing? You don't need to raise your hand, but I want to just kind of see who's familiar with gene panels and what that looks like. Okay, so gene panels are pretty common actually nowadays. In fact, if I'm being honest, I don't remember the last time I ordered a single gene in a situation like this because it's actually a more cost-efficient way for us to do upfront testing. It becomes more time efficient, and it allows us to test anywhere from 2 up to 80, well, I think it's 83 genes on that big panel now. And we do it on one tube of blood. So instead of doing serial testing where we test gene by gene by gene on one individual tube of blood, we can do all of that testing in one test on one tube of blood. And the best part is one cost. Yes?
Are you also testing the tumor and somatic tissue as well?
That's a great question. It depends on the type of cancer and what the reasons for testing would be. So most of the time, I am not doing side-by-side testing in this situation, looking at the blood and the tumor. An oncologist may choose to do genetic testing of the tumor, what you're referring to as somatic testing. That type of testing is more to determine what sort of treatments would be available for that patient. The genetic testing on the blood is to determine what we call the germline genetic mutations are, and those ones are mutations that someone is born with. They've had since had since birth, so every day of their lives. It's also in every cell of their body, and that's ultimately what led to the increased risk of cancer to begin with. So I'm typically not the one ordering the somatic testing. It would be on the oncology side. Again, more to decide on treatment-related decisions. It's a great question. Any other questions that I can clarify so far? Yeah.
So you've already been tested, but just for an individual gene, would it behoove us to go through the panel and see if there are others?
That's a great question. It sort of depends on the scenario in front of us. So for example, if someone was tested back in, I'm going to say 2005, that was, we didn't have gene panels available. They didn't become routinely available until about 2014. So if you're tested prior to that, you probably did not have a gene panel at that time. It depends on what types of cancer are in the family. It also depends on what that result was. So if someone tested positive on just one gene tested positive and they were just tested for one gene, the likelihood of carrying multiple mutations is relatively low. However, if there is a family history that's not explained by that particular gene, it might be worth proceeding with additional testing. Yeah. Okay? So in this case, we're talking about gene panel testing when there are multiple types of cancer in the family, multiple possible syndromes that are associated with those types of cancer. So in this case, it's HDGC and Lynch syndrome. And in this case, again, cancer on both sides of the family. So if we have a mutation coming from one side, that doesn't explain the opposite side of the family as well. On the flip side of that, we're also doing what's called single-site testing, or testing for a known familial mutation. So this might also be familiar to some people in the audience today. In this case, you can see there's actually no cancer on the mom side of the family. It's all clustered on the dad's side. And the most important piece here is that multiple family members have tested positive for a CDH1 mutation. So in this case, say my patient's brother is coming to see me now, I'm going to offer him testing for that known familial CDH1 mutation because I know what's causing the cancer in the family. There's nothing on the opposite side of the family. The family history of cancer fits that gene and fits that particular syndrome. So these are all reasons that I might choose a different approach to genetic testing. In this case, offering that single site or that single mutation testing instead of a panel approach. So this is just to highlight the piece that genetic testing, again, is not one size fits all. And while your neighbor down the road might have had a full panel, if your family history and there's a known mutation in the family, the genetic counselor might be offering you just that one gene. So don't take it as, I didn't get what my neighbor got. It's probably because that's what's best for you in that moment. All right. A word about direct-to-consumer genetic testing. Has anyone heard of 23andMe? Okay. So I just wanted to touch briefly on not 23andMe in particular, but direct-to-consumer genetic testing in general. This is popping up all over the place. I think on Black Friday I saw at least 3 specials about 23andMe, Ancestry.com, et cetera, on Target's website, on Amazon's website. It's everywhere. You can just buy a genetic test at CVS nowadays. So I want to point out that this is different technology than what we are offering as genetic counselors for our genetic testing. It is not the same type of genetic testing that we are running for our hereditary cancer syndromes. We may or may not be able to identify all genetic mutations that are associated with disease because of the way this testing is run. And because we're not able to identify all of those mutations, there is the possibility of false positive and, in some ways, scarier, false negative results. So I just kind of put this up as a word of caution. I think things like the Heritage or Ancestry.com, where you're just looking to see, am I 100% German? Do I have a little bit of Swedish in there? That's all good fun, that's fine. But if you're looking for health information with regard to genetic testing, the best approach to that is to see a genetics professional and undergo testing that really is the best sort of clinical genetic testing. Ultimately, because if a patient tests positive on 23andMe and they've paid $250 to get that test, I'm still going to tell them they need to have the clinical-based test and still pay that extra $250. So you might want to just start with the $250 through a genetic counselor and go that route instead. Questions about direct-to-consumer testing? I'm happy to talk more about this if anyone has other questions. I just kind of put it up as a word of caution moving forward. Yeah. So these are not actually gene panels that are looking at specific genes. What they're actually looking for are what are called single nucleotide polymorphisms, or little changes throughout the genome. They are also not providing back information necessarily saying you have a CDH1 mutation. And so what is happening is that the direct-to-consumer testing companies like 23andMe is releasing what's called the raw data, so files in a form that I can't read, but then you kind of input your data into a third-party interpretation service. It's all available online. You just upload your file, and then it spits out you have this mutation, or you have a mutation at this place in this gene. It might be associated with X, Y, and Z. So they might come back with a CDH1 mutation. Now, I have tested multiple patients who have brought in these reports and said, this tells me I have a BRCA mutation, or this tells me I have, a CDH1. I haven't actually had a CDH1 come through, but BRCA 1 and 2 I have had a couple of times. 50% of the time it's actually been positive, and 50% of the time it's been negative. So there really is that possibility of false positives and false negative results. Yeah? Oh, as far as that goes, so if there is a mutation detected on the genetic testing that I order, I trust it entirely. Primarily because the laboratories are actually doing confirmatory testing. So they're running one type of sequencing called next generation sequencing. And when they find a mutation via that sort of testing, they're running a second different test to confirm that that mutation is actually present. So they're really double checking their work throughout. The type of testing they're doing is very, very accurate as well. The caveat to that is we don't know everything about genetics right now, right? So what we're testing right now, if someone did, say we did a 14 gene panel back in 2015, that means those 14 genes might have been negative, but that doesn't mean all of the genes are negative for mutations, right? The other thing is technology just does change over time. That next generation sequencing that I was mentioning wasn't available until we started offering these panels in 2014. So the testing technology changes, which also potentially increases the chance that we find a mutation with newer technology too. It's a great question. Yeah?
Hi. I have a question regarding Invitae is going to having a patient-initiated
Yes.
testing. Yeah. How that going to change the direct-to-consumer testing and CDH1
That's a great question. And so Invitae is actually offering their same clinical testing that we would offer to our patients in our genetic counseling programs. They are just offering it. It's slightly nuanced way of putting this. So direct to consumer would be like 23andMe. Invitae's testing is what we call consumer directed, meaning they are the ones to initiate the process, but it still goes through a physician. It doesn't need to be that patient's physician, but it still gets signed off by a physician. It also is the same type of testing that they're offering to their patients via the genetic counselor. So it's the same technology as we would be offering. It's a really good question. Yeah. I'm happy to talk more about it if you have more questions, because they just launched that and I'm excited to see where it goes. All right, so I did want to talk about, I think I have a couple more minutes, I'll wrap this up quickly. I wanted to talk about the possible test results. So this is something I go through with every single one of my patients. Anytime we do genetic testing, there's 3 possible test results. Positive, meaning we found a mutation. Negative, meaning no mutations were detected. And then the last one here is sort of that gray area I was talking about, variants of uncertain significance. So a positive result just means we found a harmful mutation that's increasing the risk for one or more types of cancer, and that is that result that we would that would allow for family member testing. Negative result would mean that there are no mutations detected, but that does not eliminate an increased risk of cancer for family members necessarily. So it depends on who was tested first, if we know there's a mutation in the family, or if that person was the very first person to be tested. And I think I've already touched on this, but this is also based on what's currently known about cancer genetics. Obviously, that is subject to change as we learn more and more about cancer genetics. Now, the variant of uncertain significance is sort of that question mark result. It means we found something in the gene, but we're unclear if that particular change is associated with an increased risk of cancer or not. In these situations, we typically are not offering testing to family members. If I don't know what it means for that person sitting in front of me, I have no idea what it means for their family members either. And this also means family members may still be at an increased risk for cancer until we're able to determine if this variant of uncertain significance is harmful or not. In some of these cases, labs will offer what's called family variant studies, where we'll test other family members who have had cancer to see if they also carry the mutation. And then I wanted to touch very briefly on this amazing working group. So the ClinGen CDH1 working group is a multidisciplinary team. So we've already talked about what a multidisciplinary clinical team looks like, but this is a team of individuals that includes MDs, PhDs, genetic counselors, and they are working to reclassify uncertain results, those variants of uncertain significance, specifically in CDH1. And they have actually defined specific guidelines for how they think CDH1 mutations should be classified. This is a little bit different because a lot of labs are using one type of criteria for all genes. In this case, this working group is defining specific criteria that they feel should be used for the CDH1 gene in particular. And with these guidelines, they were able to, they were looking at a very small number of mutations, but they were able to reclassify. There were 20 variants of uncertain significance. They brought that down to 14. That doesn't seem like very much, but I will say variants of uncertain significance oftentimes take years to reclassify. So the fact that they were able to reclassify even 6 just with these new guidelines is really exciting to us. So just to kind of wrap up, genetic testing really is there to help define the risk of cancer in families, and there are many different genes and syndromes that involve gastric cancer risk. So there might be multiple different approaches that we need to take to for genetic testing at this point. And then just a word of caution that results of genetic testing really must be interpreted very carefully, and I think at this point it still is helpful to do that in the context of working with a medical provider or a genetics provider. And with that, I will wrap up, and I will bring Dr. Kupfer back up. Thank you so much. I should say, if anyone has any other questions, I'll be here for the rest of the morning, so I'm happy to take any of those outside, too.
So I also just wanted to thank Jessica in particular, but all of our speakers, all of our professionals here are doing this on their own time on a Saturday. And so I just wanted to have a little token of appreciation from New Zealand. So thank you. All right. So we're going to move on. This is a packed program. I learned a lot. All right. So I am going to tackle the question of endoscopic screening in HDGC. And the question that was posed is, does screening with endoscopy work in HDGC? And I'll just answer first with this. The preferred management is total gastrectomy. I think at this point we're still not quite at a place where we can, with 100% confidence, say that endoscopic screening works. And so I just want to lay that out there, that right now in 2019, the preferred management for a CDH1 mutation carrier is total gastrectomy. So we're going to go back to the stomach. So just to remind you of the different geographic locations that we talk about. And importantly, and Dr. Semrad, who has joined us here, who is our nutrition expert and really a world-renowned endoscopist and nutrition gastroenterologist, she's going to talk about the important functions that these different regions have. So this isn't just to help us, sort of figure out where we are. They actually functionally are of importance. But just to remind you, the different locations: the cardia, fundus, body, antrum, pylorus. I had mentioned this word transition zone, so we kind of refer to that as the area where the body and the antrum sort of come together. There are no little signs up that say, hey, you've entered the body, or here you are in the fundus. So some of this is just our feeling of, we know anatomically where we are. So also, sometimes this becomes confusing. There are a lot of different names for the same procedure. So the official name is esophagogastroduodenoscopy. And that's just too much to say, and I trip over it every time. So we refer to it as EGD. That's what it stands for. Sometimes you'll hear us talk about upper endoscopy as well. These are all synonyms for the same thing, so I'll use these interchangeably. So what is an EGD? So this is a procedure that is done typically as an outpatient procedure. Sometimes we do this when people come into the hospital for certain circumstances, but typically it's an outpatient procedure where an individual is sedated with medicines through an IV to make them sleepy, and essentially a flexible tube that is not much bigger than my index finger here is inserted into the mouth, and it goes to through the esophagus, into the stomach, and reaches the first part of the small intestine. I mentioned that's called the duodenum. And so this is essentially what you're looking at here in a cartoon form, and you can see here the little light camera. There are also channels in there so that we can put tools through so that we can get, for example, biopsies, or if we would have to remove something like a polyp, we can have little lasso tools that we can go through there. And also if we needed to stop bleeding, for example, we have tools that we can use to burn or to clip. And importantly, for those who have had surgery, sometimes we can use tools through this scope that help to stretch out parts of the gastrointestinal tract. For example, where a surgery has been done, if there's a narrowing, we can use a balloon or other tools to stretch out that area. So this is what we're talking about when we're talking about an EGD, and I'm sure that many of you in this room have had an EGD procedure. So I showed these nice pictures, right, bright and early. So this is what we are looking at, and I mentioned that for the intestinal type of cancer, again, they are, for the most part, have some visible changes that we can see with this camera. And I should mention that these are magnified images, and the scopes now are becoming, technology is advancing, they're high definition for the most part. And there are additional tools, and I'll be mentioning these as we go along, but even on these standard, what are now kind of considered standard scopes, we have different light filters that can help us to look at blood vessels in different ways. We can also spray things onto the lining so that we can see things better. So there's a number of enhancements that we can use to help us see better. I mentioned that, however, for diffuse type of cancer, it becomes very difficult to identify where there might be these cancerous cells kind of hanging out under the lining. And just to remind you, this is again the fundus area here in parts of the body looking through this EGD scope. And you can, as I mentioned before, what we're looking at is this lack of distensibility. Those cancer cells have infiltrated into the lining. But really, and Dr. Semrad can tell you, the actual lining itself doesn't look that abnormal here. It's just that it's thickened and doesn't blow up like a balloon like we would expect it to. I also mentioned that here we're looking, this is now that you're becoming familiar with this is that pylorus. That's that sort of gate between the stomach and the small intestine. And it's an important place because basically that's what is sort of the gatekeeper for having food go from the stomach into the small intestine. And you don't want that to happen necessarily all at once, because then when you have sugar, for example, in the small intestine, you're going to get all these signals that you should have more insulin production. So Dr. Semrad will be covering after a surgery, you may have heard of something called dumping syndrome. So this is essentially, the pylorus is one of the things that helps protect in our complete anatomy from having dumping syndrome. But suffice it to say that when we're looking here in this transition zone in the antrum, the other things we might see in hereditary diffuse gastric cancer are these more pale areas. Sometimes they can also be raised, but they're extremely subtle. And even under a light filter that helps us to see blood vessels better, called narrowband imaging, it's still kind of difficult to see this. And you could imagine just kind of flying by this if you didn't know what you were looking at. So sometimes, and some of you have probably heard me say this, is sometimes it feels like this is looking for a needle in a haystack. The stomach, when it's really distended, has a lot of surface area, and we're looking for area, these very subtle areas. And by the way, these areas of cancer can also be here and there, and so they're multifocal, we call them. So it really can sometimes feel like a needle in a haystack. So just to come back to this case, so you can see these kind of findings here that I was very suspicious that this was already advanced diffuse gastric cancer. So I went in knowing that I was going to find something. Of the 40 biopsies I took, 2 had the intramucosal signet ring carcinoma. So by intramucosal, it means it's sort of been sitting under the lining and hasn't gone deeper down. And this is just sobering for me as somebody who thinks when I'm doing a colonoscopy, of course I'm going to find the polyps if I just look hard enough, or if I just use any kind of tool that I have, I can find everything. In this case, I can't be that sure, and that makes me nervous and makes me want to have better tools and better ways to screen for this cancer. But it also makes me realize that really still the gastrectomy is the way to deal with this definitively. So there have been some folks that have gotten together and have talked about screening in HDGC. And right now, the expert opinion, as I am telling you, is that the recommendation is not to perform endoscopic surveillance. By surveillance, we mean going back every 6 to 12 months and getting more biopsies, and then, hopefully we'll hit on that one area with the cancer, and that could help someone to make a decision about gastrectomy. And so still, we do not recommend that as the first line. Now, and so prophylactic surgery is still the recommendation. Now, I know there are people here and other patients that I have who say, I'm not ready for that. I am absolutely not ready for that, to have a total gastrectomy. And I understand that. Everybody has a journey and a process to go through. And so I say we're not going to leave you hanging. Of course, we're going to do everything we absolutely can to try and find this early so that you can make a more informed decision. That being said, I do have to always have the caveat that I might miss something. And especially in this syndrome, I really, even with in the best hands taking, and I'll show you, even taking double the number of biopsies that we've been doing so far, it's still imperfect. But for those who are not ready yet, we do have a protocol that we use that was developed in Cambridge in England that helps us to have at least some standardization. And I think we're continuing to develop this protocol, as I'll show you. But essentially, it's about a 30-minute procedure. So this is longer than what we use standard upper endoscopy, which can take somewhere between 5 and 10 minutes usually. We really take our time in the stomach to really try and identify those abnormalities. What we do is we go in and we insufflate and deflate. So what I'm looking for is that balloon phenomenon. I want that stomach to really insufflate. I want to not see those folds. If I don't have that, if that's not happening, I start to worry. I then do a very careful assessment of the entire stomach for anything that looks abnormal, visible abnormalities. And so I'll talk about some of those, but that includes things like pale areas, any nodular or raised areas, anything that doesn't look like the typical stomach. And then we do, in addition, so we'll sample those with small forceps, little tools that get samples of the lining. And then in addition, we'll do random biopsies. By that we mean we'll just go through the stomach systematically in different areas and take a number of biopsies, again, to try and get that needle in a haystack. So here are some more images. So here is from the Cambridge group when they published this. You can see here, again, that pale area, and this is the case that I showed you before, these pale areas. There can also be these raised areas, this sort of nodular area, and then you can have maybe what we call an erosion, a little bit of a change in the lining. All of these, again, extremely subtle, and someone may look at that and just say, oh, that's just part of the normal stomach. So the group in Cambridge actually looked at this and they asked, where do we find these foci, these little areas of cancer in the stomach when we do it by a scope versus when we've taken the stomach out and we look at all of the regions? And you can see here what they're showing is when it was done with endoscopy, that protocol I talked about where there were targeted and random biopsies taken throughout. Of the 42 biopsy specimens here, you can see that most were from that fundus area. When you look at the gastrectomy specimen, however, those were 80, so you have to kind of do a little bit of math here. But you can see that the fundus and the body were kind of equally split. So it means that possibly when we do scopes, we're missing these areas when we do the biopsies in certain regions of the stomach. And I mean, I can understand this. The body is a relatively large surface area. And so again, it depends on if you happen to hit on that area or if there happens to be some kind of visible lesion in that region. So in their hands, they reported that they were able to detect signet ring cell carcinoma. So those are those little areas with those signet ring cells in about 61% of those cases over a span of several years of doing serial, meaning doing one after the other every year. They were able to detect it in 61% of cases. This is a picture that I took, and Dr. Davis hopefully will elaborate on this. This was a presentation at our national meeting just a few weeks ago where a gastroenterologist from the NIH proposed a different kind of screening protocol, a systematic screening protocol, which doubled the number of biopsies that were being taken with the standard protocol. And you can see here, these are the detection rates that they reported. So in 25% of they randomized these people, meaning they just sort of took one person and put them into the standard group and another group that went into this the systematic screening group. And what they found with the standard procedure, which is still taking, a lot of biopsies, in 25% of them, or in 25 cases, it was a negative procedure, and 4 of them they were able to identify the signet ring cells, so that's a detection rate of 14%. Using this systematic screening protocol, which amounted to approximately 80 biopsies throughout the entire stomach, they had a detection rate of 36%. So it seems like taking more biopsies yields more results. I will, however, point out that even there, 52 individuals still had negative. And we know that for the most part, for most cases, when they go to a surgery, an area of cancer is still identified. So we still need to do better. And it was interesting because someone came up and said, okay, so we can take more biopsies. Are we providing patients with a false sense of reassurance that, oh, your screening was negative, we did an even more systematic screening protocol, but how is that interpreted? Are people going to feel like, okay, well, you took 80 biopsies and there was nothing found? I think the jury's still out, and I'm hoping that Dr. Davis can talk about that when he presents on his group's work. This is really important stuff, and this is the kind of thing that I think we need to do much more of, and we need to collaborate and really help us to understand how can we make surveillance better. And I don't know if you're going to touch on this, Jeremy, but there are new tools. I told you that there are new technologies that are helping us to enhance our ability to see what's going on in the stomach. And there is this approach or this tool called confocal endomicroscopy. Essentially, this is using a standard scope, that EGD scope, and using a special tool that allows you to almost look like a microscope onto the lining of the stomach. So these are images of normal stomach up here, and you can, if you remember what that picture looked like of what it would look like under the microscope, and Dr. Setia has joined us, and this is what she would be seeing under the microscope. This is what we can almost start to recreate using a scope. So it's really cool technology, and you can really then try to see can we actually start to identify those little foci? So instead of relying on these kind of non-specific, subtle findings like pale areas, etc., can we actually be more targeted using an endomicroscopy technology? So I know Dr. Davis and others are looking at this, and I think this is very promising in order to help us improve our surveillance. So in conclusion, and I have some time for questions, which is good, still today, total gastrectomy is the treatment of choice, and I think that's because endoscopy is still imperfect, and we miss foci. Now, and maybe this will come up in later talks as well, the question is, just having those cancer cells sitting there in the lining kind of doing nothing, is that okay? Can we just watch that? We really want to keep it from getting to that stage where it starts to invade. I think we just don't know when that happens and how that happens and in whom that's going to happen. And so I think we still need to have the goal of getting these out when they are still sort of stuck in just to the lining. Endoscopy should always be performed by someone who's experienced in looking at diffuse gastric cancer and doing this screening, and there should be targeted and random sampling done. And then I think we're moving, work by Dr. Davis's group and others really are helping us to figure out what is the optimal screening protocol, and more is probably better, and we'll actually be able to detect more. But I think it still hasn't been fully established what really the complete optimal protocol will be. And also, what level of confidence can we have in telling people, okay, well, so there was nothing here when we took 80 samples, so let's, I think you're okay to go for another year. I think we're not quite there yet knowing how confident we can be. And so I'll thank you for that. I'm happy we have a few minutes right now before our break. I think that's next, yes, to answer any questions about endoscopy. Yes?
It's not exactly endoscopy.
Sure.
And I apologize.
No problem.
From my part, I live in Washington, D.C.
Okay.
And I have an associated genetic list.
Yes.
And I went to a Dana-Farber conference in March on Lynch syndrome.
Mm-hmm.
And the keynoter, the reason I went was the leading researcher on Lynch was doing a trial on aspirin dosage.
Yes.
It was in the STIR trial.
Dr. John Byrne, yeah.
Sir John, who's been my
Sir John, I know.
So what I found fascinating about that conference, and I'm in 2 Facebook groups, and you can see the difference in diet. So I'm in a group in the UK, I'm in a group in the United States. And the people in the United States embrace more of some of his conclusions, and his conclusions were, do everything that garden variety cancer you might be able to beat. Get on a plant-based diet, exercise moderately, like 150 minutes a week, and,
Yeah,
get on aspirin for us.
yeah,
So the fascinating part is the people in the UK are like, no, I'm not picking up my meat and my sausage.
yeah.
And the people in the US are like, really? That's what I need to do. So
Yeah.
I just wonder if you could speak to that,
Sure.
your issue. And
Sure.
Because I walked in and I saw these treats, and they have red dye number 1, and they have preservatives.
Yeah.
And they don't have the kind of organic and stuff that
Yeah.
he was suggesting.
Yeah. It's a really great point, and I think the way that I approach this is I think that a healthy diet is good because it's healthy, and it's going to impact everything. So people who have hereditary syndromes are still at risk for cardiovascular disease and et cetera. I think the question becomes what is driving most of the risk in a hereditary syndrome. So I usually think of it like this. What is the genetics doing in terms of the risk of cancer, and what are the lifestyle, we call them lifestyle or diet or et cetera, aspirin use. How is that impacting this risk? So in many hereditary syndromes that we're talking about, including HDGC, but also in Lynch syndrome, the genetics really are driving most of the risk. Now, that doesn't mean you have to be fatalistic and say, oh, well, it's just the genes and I should, eat whatever I want. Because we don't know what that other, how that sort of changes the risk, if it can reduce the risk. In Lynch syndrome, we have more evidence that things like aspirin, obesity, all of these things impact and can change the genetic risk. Or modify it is probably a better word. I think in HDGC, which is one of the things that we're talking about here, we don't have enough of that evidence yet to know how some of these things might be modifying. I will say that, for example, we know that H. pylori is a risk factor for gastric cancer, and so I think it makes a lot of sense to treat H. pylori if it's found. This is the bacteria that can be that's in the stomach and is a risk factor for gastric cancer. Because it might be, for example, there is some evidence that having an infection in your stomach and that inflammation may actually be one of the things that pushes those cancer cells to start, becoming more invasive, because that inflammation may change the sort of how the other gene, right, because you have two copies of these genes, and you have one that's defective, and the other one has to become defective through something that's happening. And so inflammation is one of the possibilities. So I absolutely think that there are modifiers in hereditary syndromes. The question is, how much of a modification is it? And I don't think in HDGC we have enough to really make firm conclusions. I think I always go back to, what would your mother say? Like, what's a healthy diet? Exercise, all those things are good for health overall, but exactly how that's going to impact your risk and whether that means you can not do something like surveillance, certainly we're not there yet.
I'm not saying you should surveil, I'm just saying the evidence for Lynch seems to be only a step ahead of what's going on.
Right. No, I completely agree.
So the evidence for Lynch 2 years ago, but they come out with evidence in, I think, a Finnish study and a French study that an organic vegetable diet reduces Lynch 25%. That's
Yeah.
a pretty big number.
Yeah, no, and I think we need more research, and we certainly need to include other hereditary syndromes in that. And I think especially those in the gastrointestinal tract are especially important, because that is where the outside and the inside meet. Our skin is one of them, but our GI tract is open to the environment and is open to what we eat. And so I think it makes absolutely a lot of sense, but we need more information at this point to make evidence-based recommendations. But I will say that a healthy diet and maintaining a normal body mass index and exercising are absolutely important. Other questions? Yes?
Yeah, about the H. pylori.
Yes.
In this control or maybe eradicating, is it still a risk? If one has had it and if you no longer have it, is it that risk factor still there for always?
Yeah, so it's a little bit of a subtle question. I would say that the risk goes down when it's eradicated, and you want to make sure that it's actually gone, because there is resistance to antibiotics for H. pylori, and so we recommend, especially in people who are at increased risk for stomach cancer, that they make sure that the H. pylori is eradicated. And you can do that in a number of different ways, and I'm happy to talk offline on that. In some cases, and this is not specifically now for HDGC, so this is more in the general population, and for example, in Asian countries, there's a high prevalence of H. pylori and a much higher prevalence of gastric cancer overall. So they actually do screening for stomach cancer in the general population, because the H. pylori, having had it for a long time, like from childhood, can start to change. Remember that stepwise progression. There can be inflammation, and then there can be changes in the lining to a more intestinal type. And so even if you've eradicated the infection, some of those changes may still be there, and they could still be risk factors. But it's really dependent on whether those changes are already there. I would say that I always check my patients for when they have high-risk syndromes for H. pylori, and I make sure we eradicate it. And then I'm looking for some of those other changes. But so it's a little bit more of a complicated question, but for the most part, we want to find it and eradicate it because that will reduce the risk. Yes?
Is there any other options for surveillance besides endoscopies? Is there any research being done that's less invasive at all?
It would be great. It would be great. No, right now so what would be great is to have a blood test where we could check and say, even something where we could risk stratify someone and say, you have a marker, maybe you should be getting more intensive surveillance, or a marker that could tell us you have cancer, you don't have cancer. I will say there's a lot of work being done. So now the technology is such that you can actually identify tumor cells within the blood or even just DNA from a tumor in the blood. We're not there yet for screening for any cancers using that kind of technology. Right now it's being tested for patients who have cancer, and you're trying to see if they've responded, and you want to make sure that they don't have any more of these circulating tumor cells. I think the technology is moving rapidly, so hopefully one day we could have something like that. By the way, it doesn't need to be the actual tumor cells that we're looking for. It could be other markers or other measures of cancer development, but they have to then get into the blood somehow. And these cells tend for a long time to just kind of sit there dormantly in the stomach. And as yet, there are no particular markers that we could potentially test for. So it would be awesome, and I think we should be moving in that direction. I think for now, though, the direction it's going to go for surveillance in the stomach is using technologies to help us see better and to find those foci that are there. But ultimately, it would be great if we could just do it with a simple blood test or maybe spitting into a cup or something like that. But that's the future. All right, so I don't want to shorten our break. So we're going to take a break now for about 15 minutes, and we'll come back to talk about surgery. And hope everyone had a nice break. So as I mentioned at the end of my talk, really the management for HDGC is gastrectomy. And so we have a really important speaker now who's going to tell us all about what that entails and how decisions are made. This is Dr. Kevin Rogan. He is a professor of surgery here at the University of Chicago, and he is an expert in surgical oncology and performs robotic surgeries. And I think he's going to sort of mention that to you because we've been talking about technological advances and how that's impacting our practice. And certainly robotic surgery is sort of the next wave in surgical advancements. So with that, I will have Dr. Rogan tell us about prophylactic gastric surgery. Thanks.
Thank you, Dr. Kupfer. So first of all, it's my pleasure to be here. I'm overwhelmed by this turnout, and I look in this audience and I see some of my patients and I see this amazing group, and it makes me want to do more to help. So I want to say this: if there's anything that I can do to support this organization, I would be happy to do so. And this is a really important topic because many of you have been diagnosed with the CDH1 mutation or know someone that has, and the decision about how to have that goes into having a prophylactic or complete removal of the stomach is as charged and emotionally difficult as any that I have in surgery, because whether it's culture or families, we put so much emphasis on the meal and eating. It's our time of interacting. And to think that you might lose that opportunity because of this disease that you were born with is something that is very, very difficult. And so hopefully at the end of my talk, it will be less stressful if you're going through the process. And I look forward to hearing many of the patient stories, because I think that is really where it's at, is to hear it from the patient, not from necessarily me. My only disclosure is that Intuitive Surgical did sponsor a portion of my robotic training 3 years ago. So to zoom back out on the problem, gastric cancer worldwide affects 1 million people each year, and 700,000 die of gastric cancer. And so one of the issues with this disease is many of you have an insight that others do not have, which you know that you're at risk. And many people walk around and the first sign is they have pain or they're losing weight unexpectedly, and they are diagnosed with, unfortunately, late-stage gastric cancer, which is a lethal prognosis that affects and kills 70% of the patients that are diagnosed with sporadic gastric cancer. And early diagnosis in almost every cancer is associated with improved outcomes. And so in some ways, this is a curse, this disease. In other ways, it's an opportunity and a blessing because you have time to think this through. You have time to get multiple opinions from providers, both in Chicago, at the NIH, or wherever you feel comfortable. And I think that's really key. And so I want you to empower yourselves to take advantage of these resources, people that are willing to talk to you on a Saturday. And I hope that you understand that we don't want you to get gastric cancer. And if you get it, there's still things that we can do, but by then it's almost too late. And this just shows that most people, the survival is proportional to is related to the time at which it's diagnosed in the stage of disease. So many of these slides will be quickly forwarded through because they've been aptly discussed in prior talks, but diffuse gastric cancer, gastric carcinoma is an aggressive cancer, and the survival at 5 years in patients that have it usually does not exceed 30%. So it's very similar to the sporadic or intestinal type gastric cancer. And what's interesting about this is that the peak age of incidence, if you inherit the mutation, is 38 years of age, which gives some frame of reference of when we should be having these discussions about when to potentially consider undergoing a prophylactic gastrectomy. And, you know, there's this two-hit hypothesis. You're born with this germline mutation in CDH1 or one of the associated genes that is yet to be fully elucidated, but you need a second hit, and that second hit can come at a variety of times in one's life, which leads to sort of a difference in penetrance or the expression of cancer between males and females. So it's estimated that 70% of males will get this cancer in their lifetime if you have the CDH1 gene mutation, and 58 or 56% of females. And so that gives us some frame of discussion in terms of who's at higher risk, when we should be having these discussions, and it sort of sets the stage. I'm going to go through this very quickly, but I think it's been emphasized that diffuse type gastric cancer is different than a mass-forming gastric cancer. So we have very few clues in looking at the stomach on endoscopy about when these occur. And as you can see in the right-hand column under diffuse, this is where the familial type is, and there are some different associations that can be helpful, but most of the time you're diagnosed based on family history and genetic mutation analysis, and that sort of helps us identify who's at risk. So people that we should be considering operations on rather than who should have it are those that have tested positive for a pathogenic germline mutation like we've discussed, that have the germline mutation and they're from a hereditary diffuse gastric cancer family, and that there is this sort of group of patients that have been found to be positive on some sort of multi-panel gene testing but do not have the family history. And that last group is probably the most important to seek additional counseling from a center that's certified like ours or professionals like Dr. Kupfer and myself to discuss risks and benefits of intervention. So you're a CDH1 gene carrier. First thing is remain calm. There's plenty of resources that we can direct you to. I do think you should see an experienced surgical oncologist who does high-volume gastric cancer surgery, because this is not like a hernia repair or a gallbladder surgery. This is something where the volume of surgery that a provider performs on an annual basis is related to the outcomes, like pancreatic cancer, which is another cancer that I treat. If you have the CDH1 gene mutation, you should always have an endoscopy. That's different than surveillance or screening. This is if you have the gene mutation, you should have a preoperative endoscopy, because whether or not you have cancer detected does affect the surgical planning, and I will get into that nuance. And it also, you know, we see from time to time patients that have a family history were diagnosed late and they have advanced gastric cancer. And again, that can help us determine whether surgery is appropriate for those individuals. A CT scan, a CAT scan, you probably had CAT scans for other reasons, but a CAT scan can be very helpful for the surgeon to understand like a roadmap, if you will. And many people are born with anatomic abnormalities or have had prior surgery or could have something else discovered, like unfortunately metastatic disease spread to other organs. And this can really help understand whether surgery will be helpful as part of the planning process. And I strongly encourage second opinions because I know that there are many other outstanding providers, and maybe it's a confidence thing, maybe it's a location or a financial decision, and I think those are really important when you're in this situation. This is taken from the latest guidelines on hereditary or CDH1 gene mutation carriers, and to put us where we are in this algorithm, this is after diagnosis. And unless the patient is not a candidate based on other risk factors, you're considering prophylactic gastrectomy. So this highlights the importance of why it's important to see other people before you see a surgeon, but when you're diagnosed, I think meeting with a surgeon to get their perspective on the risk, what the surgical outcomes look like, is extremely important. So the first question that people ask me is, can I live without my stomach? And many of you, my 5 or 6 patients in the audience, can attest to that you can. It definitely is different, but you can live without your stomach, and it is important to understand that. So what does your stomach do? Well, principally, it prepares and holds food that you eat as a reservoir in preparation for digestion. It also starts the digestive process. The digestive process actually starts in your mouth, continues in your stomach, but that is a non-critical part of digestion. And so it's very possible to eat and maintain weight even without a stomach because most of the absorption occurs in the length of the small intestine. And so many people wonder whether or not they can go on to live normal lives after this. And I say absolutely that you can, but you have to understand what's different about life after a total gastrectomy. And this is like a more technical view, but this is meant to show complexity. It's meant to show why people that do this often should be doing it, because the stomach is connected to the esophagus, which is connected to the duodenum. It's in close proximity to the spleen, the aorta, the liver, and so you have to understand the anatomic relationships and what's different about individuals so that you can individualize the approach to surgery. So what is a total gastrectomy and what does the operation entail? And some people prefer to use, instead of prophylactic, the term risk reduction, because everything in life that we do is a risk-benefit ratio. And what may be good for one person at 35 years of age may not be the same decision that we would make if you're 80 and in good health. And so that's why it's really personalized. But in principle, what we need to do is we need to remove the entire stomach. So that means that we have to be above the stomach in the distal or end of the esophagus, and we need to go all the way down to the duodenum. And to show you, that means that we need to be here at the end of the esophagus and here at the end of the stomach. Intraoperatively, when we remove this, however technique that we do, we need to analyze the margins to assess, did we get it all? And that's really critical. And sometimes we think we did, and on final results we did not, and that's unfortunate, but there's limitations in terms of how high we can go without extending this operation into the chest, which is associated with harder or more difficult outcomes. In terms of the removal of lymph nodes are filters that are all over your body, and these filters can collect or trap cancer cells that have spread from the stomach where it started and then grow within a lymph node. So you have tons of lymph nodes in your body. They're important, but you can live without lymph nodes, and so they're not critical to remove them. What is critical is individualizing how extensive of a lymphadenectomy or removal of lymph nodes we need to do in an individual's case. And it goes from nodes that are around the stomach, which is a D1 lymphadenectomy, to lymph nodes that are around the stomach and the blood supply to the liver and spleen. And this is determined by the stage of your disease, if you have gastric cancer or not at present, or you just have the gene. And this is done to properly stage patients after surgery. And it's important to understand that often we don't have all of the information at the time that we're making these decisions. So sometimes we err on the side of caution by taking more lymph nodes. And then lastly and importantly, how do we reconstruct your GI tract so that you can eat and drink as normally as possible? And are there benefits to things like a pouch? And I'll try to cover those in this talk. So a total gastrectomy, as I alluded to, is removal of the entire stomach. We keep the spleen, we keep the aorta, we keep the liver, and we reconstruct the esophagus by bringing up a limb of small intestine to make a connection between the esophagus and that. And the pouch really is describing whether there is a larger opening here or ability to accommodate food, or whether we make it as a single tube. And I will highlight some of the differences in what we know about those techniques. This is more complicated, and for any engineers in the audience, this is the way that we reconstruct it. This is called a Roux-en-Y esophagojejunostomy. And the reason that we do this is we want to avoid the complication of bile reflux into the esophagus and throat. And so by making this length of this limb at least 35 to 40 centimeters, there is a hydrostatic pressure that builds in that column that prevents reflux. And so this is more of a functional reconstruction that is associated with better outcomes than if we just brought the intestine up without doing this sort of complicated diversion. So in terms of timing of surgery, this is unknown. The optimal timing is unknown. And we should start considering this obviously once the patient becomes 21. There have been reports of gastric cancer developing in minors, but it's very rare. But surgeons can be involved at any step in the process after diagnosis. But we don't know when the optimal time is because of the rarity of the disease. But what I can say is that it's an individualized decision. It has to do with whether you want to have a family, if you're going to be bearing children, what your job is, what your lifestyle is, what you do for a living. These are all really important considerations, and they're not too trivial to be an intricate part of the decision-making process. Patients that have, for example, eating disorders, which we know are common, that can affect your outcome after surgery. And so those are the kinds of things that we need to talk about. Those are the kinds of things that need to be on the table. Whether you have a history of anxiety, what your overall understanding of this disease is, what your risk is. And so this is really important. And again, these are the kinds of discussions that I encourage you to have with all of your providers. I think this point has been discussed, but if you have the mutation and then you decide not to have surgery, this is not screening, this is now surveillance. And so again, as Dr. Kupfer and others have alluded to, there's a limited sensitivity to using endoscopy as a substitute for the definitive treatment, the definitive curative treatment of this disease. And again, there's a range of detection. And as we improve our understanding, maybe we'll improve our diagnostic ability. But this is a very difficult area because many of the techniques that were tried in the past, like chromoendoscopy and other adjuncts to typical endoscopy, are not effective because this is all below the surface. And so if you see a lesion, it may be the growth of an existing tumor, and that's late in the stage of disease. And oftentimes, the stomach looks entirely normal. And so, again, there are promising studies like Dr. Davis will present to you and others. This is just one that shows that was just recently presented at DDW as well, and it's like the more biopsies are better. Well, more biopsies are more risk of bleeding, they're more time intensive, they're more expensive, and again, they still may fail to show the disease at present. So if you are not going to have surgery and want to be surveilled with endoscopy, I think it would be a really good idea to be involved in a clinical trial so they can learn about this. And there are some exciting alternatives that are going on, but there are risks associated with it as well. So in terms of a surgical approach, there is the traditional open surgery. And when they say open, that usually means a big incision and retractors that are separating, pulling your skin edges apart. And then we're doing the operation by lifting up on tissues with our hands. And minimally invasive is a broad category that implies laparoscopic, robotic, or hybrid type approaches. And that's what we do at the University of Chicago, or at least offer it to our patients here. And there are some benefits to minimally invasive surgery. One is that you don't have a big incision on your belly. And none of the pictures that I'm showing today are my own patients. None of the videos I'm showing. These are all from other patients, so nobody should be saying, is that me? So don't worry. There are some theoretical advantages to minimally invasive surgery, and it has not been proven in every cancer and in every operation, and that's a really important take-home point. I'm not saying one technique is better than the other. They're all tools in our armamentarium to help patients in your situation. But theoretically, if you have smaller incisions, you may have less postoperative pain. This has been shown in colorectal cancer. You may have a shorter length of stay, although that can be variable with enhanced recovery pathways. We can discharge patients now earlier in both open and minimally invasive surgery. And there are theoretically a risk for some lesser incidence of other postoperative complications like scar formation that can lead to bowel obstruction. So at least in theory, there are some advantages to minimally invasive operations. So what is the robot? What is robotic surgery? I know there's been a lot of concerning articles in the lay press, but robotic surgery is basically a concept where the surgeon sits at a console, but that surgeon is only part of a team. There is a surgeon at bedside. So it's not like I'm in another room and your surgery is going on somewhere else. I'm actually really close to you, and I'm sitting at a console for some of the case, and other parts of the case, I'm actually at the bedside, doing this laparoscopically or using long instruments that go through little catheters or ports in the body. But what's really amazing is that I can sit at a console, I can look with 10x magnification, 3D vision, and by using these little hand controls, I can manipulate the arms of this robot to do the exact same surgery. So the way I describe it is that it's like having little hands, maybe 3 of them inside of the body, and I can also control things like the camera, how close it is, and I don't have to rely on other people to maneuver or position instruments. So it does allow more independent operating. And this is me, again, not with any of you, but this is me. I'm sitting 5 feet away from the patient. Here is a board-certified surgeon that is at the bedside. We are doing a robotic Whipple procedure for pancreatic cancer, and these can be long, tiring cases. They usually take longer to do robotically, but it's really sort of a revolution in the field, and our job now as providers to prove that it is helpful in this disease or these diseases. So it's a favorable paradigm. There are advantages over laparoscopy in terms of the visualization, the ergonomics, and that's really important for surgeon longevity, is to also be able to save your back from lifting up and standing on your feet for 8 hours. You're sitting in a comfortable console. You have the ability to lift your head out of the console. It's not like you're trapped in this booth. And so I think there are some really cool advantages. And as time goes on, as we get the ability for haptic sensation so that we could feel with the instruments, I think it will bridge some of the issues that have occurred in early robotic adaptation or adoption. But I think there's a lot of potential advantages. Why not robotic surgery? Well, the FDA has warned that when improperly utilized, that this can be a harmful technique. And I think there were examples in the literature of breast cancer surgery being done robotically and surgery for cervical cancer that was being done in the context of clinical trials or outside that had unfavorable results. And so the onus is on us as a field to define patients that are eligible for entry into clinical trials, to have quality controlled clinical trials so that we can learn from these patients and these diseases. But ultimately it's about safety. And you have to have proper training. You have to have proper supervision. You have to do this the right way. And I'm an educator and I run a residency program. And one of the tenets of me learning how to do robotic surgery is I already have done many of these operations for 10, 12 years, doing it the open, traditional technique. And after that, I went through a rigorous process of like a pilot would use to fly a plane, hundreds of hours on a simulator, and then traveling around the country to learn this technique. And I think that's the way that I would feel comfortable implementing that in my own practice. But I do think you need to be careful with it. So I am going to show some data. There are some physicians in the audience, and I'm just going to translate this. When you look at minimally invasive surgical techniques, laparoscopic gastrectomy and robotic gastrectomy, and compare it in a very statistically valid way, which is propensity score matched case control studies. This is not prospective data in clinical trials or randomized clinical trials. This is just looking at MIS versus open surgery. I think there are some themes. It doesn't conclusively prove anything, but it proves that it shows that that these minimally invasive operations have less blood loss potentially, that the ability to do the same operation can be the same in open and minimally invasive techniques, and the hospital stay can be shorter, and similar complication profiles. So this at least gives some idea that the surgeries are equivalent or similar outcomes, but it doesn't prove it. And that if you looked at laparoscopic versus open gastrectomy for gastric cancer, this is not prophylactic gastrectomy, what they had shown is that the operations do take longer, but there can be a lower risk of complications. And again, this is all how you define what laparoscopic or robotic surgery is. When we look at robotic surgery, there's not a lot of great data from the US, but there is a lot of great data from Japan, South Korea, that show in large numbers of patients, in very experienced physicians, that the robotic gastrectomy, although it takes longer, does have some of the advantages that we described without a significant increased risk. It's important to also recognize that that patient population in South Korea and Japan doesn't look like our patient population in terms of body habitus or BMI, body mass index. And so you can't necessarily make the same extrapolation that what works for their population will work for our population. But at least this is promising. And there are several other large accumulations of patients from either randomized controlled trials or retrospective reviews that confirm in a more recent cohort that this is possible. And this is perhaps the most advanced trial looking at robotic gastrectomy and looking at in multiple centers in Japan, 15 centers, 330 patients, looking at it versus historical controls in their patient population, that there is feasibility and safety data that confirms that robotic gastrectomy may be effective, and there may even be reduction in complications. And maybe this is due to the same group doing what they do well over and over again in the same population of patients. It clearly can be more costly in terms of the operative time based on the use of instruments, but we expect that to decrease over the next decade as competitors for surgical platforms or robotic platforms come into existence. So to address the topic of how extensive of a lymphadenectomy or removal of lymph nodes do you need if you have CDH1 gene mutation, well, I think this really goes to the fact of that when you have cancers that develop in the lining of the stomach, there's less likelihood that they're going to penetrate into the levels that the lymph node channels exist in. So if you have a stage 1 or T1 cancer, the earliest form of cancer after it's left the lining layer, there is an increasing likelihood that the cancer cells will get into the lymph nodes as the tumor penetrates the wall of the stomach. So I think that's an important principle. And I think that the way the lymph nodes spread along the stomach is important to understand, because if you have a cancer that is at the top of the stomach that starts to penetrate deeper, it may go to different lymph nodes than a tumor that is occurring in another location in the stomach. And so we don't know this ahead of time. You can't look at a lymph node and say that's enlarged, we should take it out. So that's why there are patterns of lymph node resections that we do in stomach cancer surgery. And again, it goes from very limited to those around the stomach to more aggressive resections. So the extent of lymphadenectomy in CDH1 gene carriers is controversial because most of the time we don't know the true depth of invasion based on CT and endoscopy before the surgery. But what I can say is even in the earliest stage cancers, that risk is not zero, and it may be higher in our patient population than seen in others like the Japanese or Eastern Asian countries. And I think that we cannot necessarily rely on their data to guide our practice for US because the genes are different, the mutations may be different, the environmental exposures may be different. So this is what we would typically, all the green nodes that you see would be nodes that we would take in a limited or D1 lymphadenectomy. So when we remove the entire stomach, these are the nodes that we try to capture. We take out the greater omentum, which is this fatty apron along the edge of the stomach, and we also take some of the lymph nodes that are further away. When you start getting into more extended radical lymphadenectomies, this is typically what they do in highly experienced centers like ours, where we can stage patients by taking more lymph nodes. With more lymph nodes in less experienced hands, that can lead to more complications. And that's what several large-scale randomized controlled trials in the early 80s and 90s showed us, is that it's not a free lunch. And just so that we are taking more lymph nodes is not necessarily better outcomes. It may stage patients more accurately so you know exactly what you're dealing with, and it can reduce the risk of recurrence in patients that do have bulky lymph node disease. But it is something that needs to be taken seriously because there is risk that can occur. And the last major topic that I want to talk about is reconstruction, because this is a typical question that patients ask me: should I get the pouch or not? And at our center, we don't typically do the pouch because it is controversial, and there are no truly convincing studies that forming a pouch versus having a single tube is better. We know is that it does increase the risk slightly, potentially, and that most of the information that guides us is the results of a single institution trial and or reports retrospectively. But there are some randomized controlled trials that did it. One that occurred in early 2000s, it was by Fine et al., and it showed that short and long-term weight loss was similar in both groups, and that quality of life improvements were not seen until well after the index operation. There are others that have looked retrospectively in a more recent time cohort, and they thought that the pouch took longer to complete, but not a prohibitive amount of time in the operating room, and it did lead to lower maybe dumping syndrome because food stayed in the reservoir longer, and there could be better quality of life. And so I think you have to analyze these factors. If someone wants a pouch, we will do it, but it's not a routine, and until there's more compelling data, I don't think that there's anything that makes us do it. But I don't think you can replace the stomach. And if you make a pouch, there are other complications that can occur. It can get distended, it can fill with bacteria, it can lead to emptying problems, but there are some theoretical advantages, and so we want to individualize it to the patients, and if they want that, we will provide it to them. This is a graphic description, or a cartoon, if you will, of how we perform the connection between the esophagus and the bowel. And so this is an Orville technique, or an EEA stapler, which is a little anvil that's placed in the end of the esophagus. We made it with a stapling device. It's a circular stapling device, and it forms an open channel. And this is an actual, not again from my patients, but taken from online, where you can see how we bring the ends together. And this is a very challenging anastomosis, and it can leak. And it is a very, one that needs a lot of experience before doing it. And there are different methods of reconstructing. But when we do make a pouch, we line up the intestine, almost fold it over on itself like a candy cane, and we make a stapled channel so it makes a little reservoir that will dilate with time. And then we make the same connection through the end of that pouch, and then we have to seal this. So there are multiple areas that it can leak from, but theoretically this can potentially lead in some patients to a better quality of life. So this next part, I have some videos. They're short clips. Again, none of them are my patients. These are all from patients with stomach cancer that we did what's called a distal subtotal gastrectomy. But again, if anyone's squeamish, you might want to turn or just step out for a second. But I wanted to show this to patients so that you could get an understanding of what it looks like to do robotic surgery from the inside, the visualization. And I have like 5 minutes of videos just to show you what the technique looks like. And hopefully it will go through. So this is like the start. Here is the stomach. And these are the instruments. And I'm controlling the two instruments you see on the left and right side of the screen. And this is my assistant that is at ready and available to help. But we can do all the same techniques that we do in open surgery with robotic surgery. And you can move the camera, and now you're seeing the stomach. This is the stomach body. And this is a case where we were going to divide the lower 2/3 of the stomach. But it's really, in some ways, a beautiful picture, and it provides us with a clearer picture of the operative field than we would get in another operation. Beautiful is obviously in the eye of the beholder. As a surgeon, I find it beautiful. This is an example of the lymph node dissection. So I'm using this hook device to lift up this pink lymph node that is a little north of the instrument. My pointer's not working, but you can really see how you can use both of your hands, and these are like having mini hands. And I'm lifting up this lymph node off the common hepatic artery, which brings all the blood to the liver, and we're burning very slowly, and I can zoom in the camera if I want. I can see with exquisite detail these little tiny blood vessels which I can burn and cauterize and prevent from bleeding. And I'm spreading the tissue, and you can see a purple structure below, which is a huge blood vessel that brings all the blood from the intestine to the liver, and I can see it very clearly, and I can stay away from it. And now I'm unzipping the tissue and trying to take these lymph nodes off these blood vessels. And when you do this open, you're like squeezing and you're straining to get at it, and you can really see it really in a way that you don't see it in an open technique. And you can be precise, and there's not the camera moving because it's stabilized and focused on a single area. And if I want to move the camera in, I click a pedal, and I bring, like the newspaper, the hands to myself, and it zooms in, and I can zoom back out, I can tilt, and there's other adjuncts. So this is just in some ways why I think the lymph node dissection may be easier to do than in open techniques. And then lastly, I just wanted to show you how we can sew. And this is like not the stomach connection, but this is the connection between the loops of bow downstream. And this is me sewing, and this is like a barbed suture, so it is like shark skin, and it holds itself in position. And then I'm suturing as I would in an open case, and I make small movements in my hands, and the instruments move. And there's a stabilization feature, so the hands aren't shaking. If you had a cup of coffee, it's not shaking in any way. But you can really do the exact same operation, which is what I want to communicate to you, that you would do in an open technique. And right now we're sealing the bow, we're sewing it, and many of you may crochet or needlepoint, but this is like a similar technique, is that we use stitches and we close intestinal openings, and this just shows that you can do it the exact same way, and it can be effective. And so I think it's important to understand that total gastrectomy is associated with complications. It's not a free lunch. And that when you do it open, this is all open results from a very well-respected center that I trained at Memorial Sloan Kettering, that the median length of stay in a historical cohort can be 9 days, and people can die from this surgery. And I think there are 2 large-scale trials showing outcomes in hereditary diffuse gastric cancer patients. The first is from the Netherlands. It involved all open surgery, no minimally invasive surgery, no pouch, and it shows that patients can require reoperations even with highly trained surgeons, and that the weight loss can be significant, 15%, but the majority of patients return to work or what they did before. But there were symptoms that needed to be addressed and managed after surgery. And Vivian Strong, who is a contemporary of mine that is currently at Sloan Kettering, has a recent cohort from their institution. Again, no pouch, but almost half of the operations were performed in a minimally invasive technique, and the length of stay has decreased compared to other historical cohorts. Again, complication rates that are not trivial, and that when patients were analyzed in terms of their quality of life, they were as expected or better than as expected in the vast majority of patients. And what's important to learn from studies like these, which tell some of the story, is that by a year, most people have stabilized their weight loss, have begun to approach what they were like before surgery. And this shows it graphically. And there are a variety of things that we need to be aware of: dumping syndrome, late dumping, fat malabsorption. And this is why it's so important to see a nutritionist postoperatively, to see your surgeon, to see your team, because they can help manage many of these complications. And even something as simple as how we metabolize alcohol can be affected by having your stomach removed, and you need things like vitamin B12 and others. So my advice, you can get sick after this procedure in terms of that you may vomit, and that scares people. Nobody likes throwing up, but this is an important thing to tell patients, is that if you overeat, you might. You need vitamin B12 for the rest of your life. Unfortunately, the part of your stomach that helps you absorb it is lost in a total gastrectomy. That we believe that nutritional counseling with Dr. Kupfer and Dr. Semrad can be very helpful for our patients. You probably will not need, you should not need acid suppression medicines, so the purple pill or H2 blockers. They're unnecessary because you've lost the ability to secrete stomach acid. And that you're probably not going to have 3 square meals a day. You might eat more like tapas style, with small plates frequently throughout the day. And I think it is important to have healthy eating choices. You may need a new wardrobe. You may lose 10 to 15% of your body weight. Some people it's a good thing. Some people it's stressful. And I think you need to talk to your doctors about how often you need to look for other cancers, like breast cancer and potentially colon cancer, although that's not been proven. And that you are at risk for hernias and bowel obstructions no matter how your surgery is done. So if you have this operation, you need to always be aware, if you had abdominal pain after, that it could be something that needs to be fixed. And I just want to stress this in my last statement, is that you are a role model. People will look up to you for having had the bravery to do this, and many of your family members will look at you as their guide to whether or not they may be wanting to undergo this life-changing surgery. And I think that it's important to recognize that, and I at least would encourage others to have the discussion, to get tested, because it can make a difference. So I thank you for your time, and I'd be happy to answer any questions.
While you're answering some questions, thank you so much. A little token of our appreciation. Questions for Dr. Rogan?
Yes.
I think my family's in a little bit of a more unique category. My son passed away at 20.
Sorry to hear that.
Because of the gene. My 13
So we have been seeing Dr. Cuffer for the last few years, getting scopes. We're probably going to come visit you early next year because the plan is between 17 and 18 actually have his surgery because of his older brother. So I just wanted to say that the level of comfort that I've gotten from seeing what you've provided is hugely beneficial for me today versus yesterday, so thank you.
Yeah, thank you for saying that. I'm sorry about your family, and I think we can help. And I think one of the things to take-home points that I can say is that just because the peak incidence is 38 for a large amount of the patients doesn't mean that you can't have a lower risk or a lower age risk that the cancer can occur. And so we have to pay attention to when the index cases occur in individual families, and that helps influence the timing of surgery. Yes?
I'd just like to make a point about nutritional counseling, to say that it is very important. It's been very important for us. My wife had the surgery, and to ask questions and do your research, because a lot of nutritionists out there have no experience with a total gastrectomy and will give bad advice unintentionally, not realizing that your system's different now and absorbs things in completely different ways.
It's a great point.
And that's a good segue because Dr. Sumrad will be speaking next, which is a world expert, so she will give you maybe one more question just so that we can stay somewhat on time, but Dr. Rogan will stick around if you want to come and talk to him.
Yes.
Yes, I just had a quick question. I had a total gastrectomy 10 years ago. So currently right now what I've seen is that I've had some issues with a bowel reflux. In terms of like, is there any way to maybe have surgery to correct that? I'm just kind of concerned because I've just seen it, come up so much.
So the answer is absolutely. You could be a candidate for revision surgery. Those are more complicated, but we have expertise at our institution. And while I don't know what the cause for the reflux in you, it may have something to do with either shortening of the length of that limb, the roux limb, and it can be lengthened by reconstructing it. And so I would encourage you not to accept the sort of symptoms that you have. At the minimum, you could see our gastroenterologist, you could get imaging tests, you could see a surgeon, and they can at least help you see if there are solutions. But I think that's, I don't feel like anyone should have to live with something. It may be something that is not fixable, but at least you can go through the workup to see if it could potentially help you. Great.
All right. So
Thank you,
stand- Yeah, thank you. And I thought my endoscopic pictures were going to make people queasy. All right, but fascinating stuff. It's wonderful. So as a great segue, we have the fortune of having one of my teachers, one of my mentors, Dr. Carol Semrad, who, as I have mentioned, is really very well known for her work, both in a number of endoscopic procedures, but also in nutrition of the GI tract. She's a professor of medicine at the University of Chicago, and she is going to talk to us about nutrition both before and after a gastrectomy. So let me bring up, where did we put your talk? Oh, it was over here. It made its way over there. There we go. Thanks, Dr.
Okay,
Semrad.
hello. Good morning still. Okay, I'm going to talk about nutrition, and I'm going to lay frameworks because each of you should see a competent, registered, knowledgeable dietitian before you go into the surgery, and that covers everything. So I rather stick with broad strokes so you know what kind of questions to ask and maybe some information about types of nutrition. But I'm going to start by the physiology talk. So this is modified of the talk I actually give to medical students. So I know this has come up, and sometimes I'm still a believer that repetition is good. I still think people should do their arithmetic tables and learn it. So I like repetition. And the biggest part is if you understand how the stomach works, then you'll be able to troubleshoot on your own. So no matter what we say, each of you are going to be individuals and react a different way. And so it's really an art. There's some science to it, but most of it is art. And art means you're paying attention to what works for you, what doesn't work, feeding that back to us, and then we can help you fine-tune it. But it starts with this very important concept of what the stomach does for all of us. And if you ever want to be in an eating contest and win, you have to have your stomach. So that requires this high part called the fundus, which automatically, when we eat, it relaxes itself. It sort of just becomes, as Dr. Kupfer said, a big bag, a storage bag. But you need that. So if you're going to eat a big meal all at once, your stomach has to be able to do that, or you'll feel extremely nauseated and you'll vomit. The second part is once we do eat, clearly digestion starts in the stomach, but as Dr. Rogan said, it's a very small percent of digestion, and clearly no absorption goes on in the stomach. But digestion, only maybe 30% of our fat is digested in the stomach. The rest, it's the small bowel, the pancreatic juice, and the bile, which you all have intact when your stomach is removed. So, but it starts in the stomach, and once that food goes in, there's a contraction here that occurs at the end of your stomach called the antrum, or the prepyloric area, and the pylorus is a big muscle, and that wants to shut off so that your body can, like a washing machine, sort of churn that food back and forth, back and forth. The stomach is a huge, strong muscle that moves and churns that food and starts digesting it. So that's the first step. So you can already say, well, what if I lost my stomach? Well, you're not going to have that ability to eat a big meal, and you're going to lose that ability to close off your stomach because you don't have one, or even close off your small bowel from the food going right from your esophagus down into this duodenum. And we'll talk about that in a minute. Oh, and the stomach also does a very important thing, and that is the measured food delivery. So it squirts out just a little bit at a time rather than all of it, a big whoosh, and all of the food comes out. Okay, so what about what we call solubilization? So here's the food, here's the stomach, and here I'm pointing out what else the stomach does. It makes acid, and acid is somewhat important in solubilizing vitamins and minerals from bound to food. It's got to free it from food to be absorbed by the carriers that are in the small bowel to take up those individual vitamins and trace elements and minerals. So in particular, it solubilizes food, so it releases calcium and iron. And vitamin B12 comes in, it's basically in meat, so the strictest of strict vegetarians who don't take any egg in the diet, of course, are at risk for vitamin B12 deficiency just from diet alone, but most people in the United States, at least, who have vitamin B12 deficiency, it's because of some loss of the stomach or absorptive capacity in the ileum. So, but here we have B12, but B12 doesn't come in as a pill, it comes in bound to food, so the acid cleaves your B12 away. And then I'm pointing out, this is just one carrier example, but for instance, I tell people, you know, don't say, oh, I should take a high zinc because that's going to keep colds away. Because if you take high zinc, it's going to compete with copper and manganese and cadmium and iron and all these other nutrients that use the same carrier to come up, to take them up. So you're out competing one element against the other. So you really want a blended amount of trace elements and minerals to come in. And remember, here we are in that area. Remember, this is called the duodenum, and this is the proximal jejunum that gets bypassed in people who have a gastrectomy. But there's also very important calcium channels. These are highly selective, so our best calcium absorption occurs through these channels in concert with vitamin D. So if you had to look at the nutrients that you're going to pay attention to when you've had a gastrectomy, the little things besides the big food that comes in, the fat and the protein and the carbohydrate, you're going to concentrate on how are you going to get enough iron in, how are you going to get enough calcium in, and folate is also absorbed up here. So those are the things you're really going to have to pay more attention to after a gastrectomy. And then, of course, once B12 is bound to intrinsic factor, it comes in the ileum. Now let's talk a little bit more about vitamin B12 because this gets down to function. And yes, we do anatomically divide the stomach, but it's somewhat divided by what the function of the stomach does. So the workhorse of the stomach is the body. Why? Because there's these things called parietal cells that make intrinsic factor and acid. And this intrinsic factor must meet up with cobalamin. By the way, cobalamin is the molecule that's called vitamin B12, so we use that interchangeably. But so the cobalamin or B12 comes in bound to protein by food. It has to be digested away. And then cobalamin over here has to be bound to intrinsic factor to go all the way down the intestine to the ileum, and then it gets absorbed. It's kind of a promiscuous vitamin. It keeps switching partners, and up it goes, down. It's a kind of a dance. So, but it is. And why it does this, no one understands why this one vitamin should be absorbed with so many different carrier proteins to get it in. So you can see if you lose your stomach, you lose intrinsic factor, and you've got to have intrinsic factor to absorb vitamin B12. So lifelong, you have to be on vitamin B12. And that's one of those vitamins you don't want to lose track of, let's put it that way, because it affects all cells in your body, including making your red blood cells, rapidly dividing cells, and more importantly, your nerves. So you develop nerve disorders that are not reversible if you become deficient for a prolonged time. So we're very big sticklers on this. Okay. Lastly is what happens when the food, now I took the stomach out of the picture, but you can see here I have the end of the stomach that goes into the duodenum here. And this is sort of an old physiology diagram, but the important part is when that regulated, partially digested nutrients comes into the duodenum, the mainly fatty acids and amino acids rapidly trigger hormone release from the duodenum to tell your pancreas to release enzymes for digestion and tells the gallbladder to contract and release bile. And that very high concentrated bile and pancreatic enzymes can attack the food and really digest it down to its basic components to be absorbed. And here's a picture of the Amazon down here. Why do I put that there? Because like the Amazon, the duodenum, we know some of the hormones and some of the neuropeptides and some of the nutrient sensors. There's all sorts of little molecules and protein carriers that are tell us when we're taking sugar in across the lining and others. But so much of it is not known that it's like a jungle waiting to be mined in terms of how all of the hormones and peptides that exist there. But what we do know, if you take a concentrated big amount of, say, orange juice, for instance, and you don't have a stomach to meter it down, then it goes, that sweet juice goes to the pancreas, triggers insulin. You get a big surge of insulin, not enough sugar there for the insulin to pull in, and then people get these symptoms called dumping syndrome, where they get very dizzy and sweaty, and it's a horrible feeling. Some people have postprandial hypoglycemia. It's a very similar feeling. People feel they can't concentrate, they're foggy, they feel like doom and gloom is happening, and it's really just a matter of getting more sugar in because it drops your blood sugar to a very low level. Okay, now let's go to the abnormal. So the normal is here on the left and the abnormal is on the right. So you could think of yourselves, and the good news is dietitians, yes, they are poorly trained in total gastrectomy diets, but they're very well trained in gastric bypass diets. And gastric bypass diets are very common in the United States. So a good dietitian who works with a surgeon who does gastric bypasses is going to know exactly what kind of diet a patient with gastrectomy needs. So the big issue is this, the food, this is you, a gastrectomy type patient would be this motif where you don't even have this little remnant of stomach. You have esophagus right to jejunum, and whether you have a pouch or not, Dr. Rogan talked about that. But you can see when the food goes down this pipe into the jejunum, where it meets up with the digestive enzymes is at this connection site. because here's your bile and your pancreatic juice coming down this way, and here's where they meet up down here. So, in that setting, yes, you have to be careful about dumping syndrome, so we'll get into that in a minute, but you can see here that these small things, and remember, sometimes it's not the weight that gets people who have gastrectomies, it's the small things, the calcium, the iron, the B12. That's what you can't see and feel that easily until you've had a severe anemia or your bones, you get osteoporosis, or you get a vitamin B12 deficiency. So you need to pay attention to the calcium, the iron, the B12, because now it's going this way, not through the stomach and past this rich Amazon jungle where you have all this capacity to reabsorb it by very highly selective uptake mechanisms. Okay, so that's point number one. A very important point. Don't have your gastrectomy and have someone say, you're fine now, your weight's fine, have a good life. No, you have to be monitored for the small things, the calcium, the iron, and the B12. So I'm going to go over the current guidelines for, I only have 2 more slides or 3 more slides here. So the current guidelines for nutrition recovery after gastrectomy, and this is based on what Dr. Rogan made reference to, ARAS, which is the Enhanced Recovery After Surgery, and it's all kinds of surgery, but there is an ARAS guideline for gastrectomy patients, and this was just summarized in one of the surgical journals in 2019. It's a Japanese group. Again, they have a lot of gastric cancer, do a lot of gastrectomies there. So just to summarize, and these are the big broad strokes because you'll keep those better than small minutia details when it comes to nutrition, is that first of all, pre-op, is there any benefit to getting, like, well, if you were going to do doping and you were a bicycler and you took blood transfusions to make your oxygen carrying capacity better, is there anything where you beef yourself up before your gastric bypass surgery? And the answer is no. If you have a normal weight and you're eating fine, then nutrition support you do not need. You do not need a tube down to feed you. You do not need IV feeding. Whether or not to bulk yourself up, or what I'm thinking going forward, just being at this symposium, is whether we start training people how to eat differently before they have their surgery. Most people have the concept, I'm going to eat my last big meal, and then I'm going to have my stomach out, so I'm going to just, you know, eat 3 huge meals every day and this and that. Well, post-gastrectomy, you're getting into the very small meals, and you have to completely change how you eat, and sometimes you're recovering from a surgery, plus you're learning how to eat different, and that can be frustrating and discouraging and, oh my God, what is my life going to be? But I don't think it has to be like that, so maybe we should look at it the reverse. We should start training you how to eat differently before you go into surgery, so it's in your mindset how it's going to be after. If you're malnourished, and there are the subset, particularly the ones with diffuse infiltrating disease where their stomach doesn't empty well because it's paralyzed, and they come in vomiting, losing weight sometimes before we even recognize that it's due to cancer. And if your stomach's coming out in that setting, then you want to have IV nutrition support or tube feeding, whichever, when we decide based individual basis. Before you go into surgery, how long? At least 7 to 10 days, sometimes longer to get your functional status up so you can recover from the surgery. But at least 7 to 10 days might be beneficial, and then you carry on nutrition support through the whole surgery. So let's say you're well-nourished now and you had your stomach taken out. Now there's a post-op course. So here, how early should you eat? And as Dr. Rogan said, one of the issues about an open gastrectomy versus a laparoscopic or a robotic approach is that people start, first of all, the small bowel returns recovery, it starts moving very quickly after surgery, maybe 1 day. You don't have your stomach anymore, the colon is a little slower after surgery. But with robotic surgeries, for instance, in a gastric bypass for obesity, when the surgeons put the patients back together, they start eating day 1, day 2 sometimes day 3. So the consensus, there's no consensus to say it's better to start early or worse. Each person is going to be individual in their immediate post-op recovery. But it's left open to interpretation. In other words, early food, not clear liquids, because those are those concentrated sweets. That's the worst thing to start people on who've lost their stomach. But small amounts of food can be good even after day one, depending on how a patient feels and how the surgeon feels in terms of how the surgery went. Some surgeons know it was a little more difficult, and they'll say, I don't want my patient eating for a few days. There were some issues. I'm a little worried about this connection site. I'm going to sit tight for a day. And then we say, fine. The second part is, what if you're eating, but you're not eating enough? So you're taking less than 60% of what you need to keep the weight you're at after a week surgery. Well, after a week of post-op surgery. So there, we start something. We try to start something before you dig yourself into that more malnourished rut where you're weak and you feel terrible and you just feel crummy. Most people who have gastrectomies, particularly preventive, are young, they work, they want to get back to work. So we should support you so you can keep your weight, not let you get debilitated and then start giving you nutrition support. We don't like that approach as nutrition type physicians. And then the last part is very important, the nutrition assessment. And here we assess people before, during, when they're in the hospital, and after, because we have the second part on that list. We have a nutrition support team that consists of a physician trained in nutrition, a registered dietitian, a nurse, and a pharmacist. And there we follow people from outpatient to inpatient to outpatient, the same team. However, not every hospital has that, and a knowledgeable registered dietitian alone is fully competent to handle your nutrition care, so you don't necessarily need a team, but you do need a knowledgeable registered dietitian in gastrectomy-type nutrition problems. Okay, what to eat? So again, I put it into what's the loss of function and how does that make you think of how you should eat? So if you've got a small pouch or no pouch, so that means you have to eat multiple small meals. What does that mean? That means 6 small meals a day. So however you spread it up, 3 snacks and small meals, or whatever you want to call a snack, you can do it how you want. The second part is you lost your pylorus, so you're going to rapidly empty food into that small bowel, and that's going to put you at risk for that dumping syndrome. So there, the first step is to avoid simple sugars. What are simple sugars? Table sugar, concentrated sweets, sodas, pops, not diet, but regular sugars. Lactose in milk can be tough. So you're going to avoid that. You're going to eat complex carbohydrates. Starches are okay, and proteins okay, and fats okay. And you're going to try to separate drinking from eating. And the reason for that is when you eat and you take a big gulp of water or liquid, it flushes that food down faster than if you just ate the solid food and let it sort of sit there. And of course, you're going to chew. You're going to turn into the 3-hour diners. No, not really. I can't even dine for 10 minutes. You know, but you have to slow yourself down. Chew, and then slowly swallow and eat slowly, because that's going to help that dumping syndrome. And then there's the loss of intrinsic factor. Intrinsic factor is made in the stomach. It binds to B12, and you need it to absorb B12. You don't have it, you're never going to have it again. So you have to either take high-dose oral vitamin B12 every single day religiously. That means 1 to 2 milligrams a day. Or you have to inject yourself once a month with vitamin B12, a 1 milligram dose. And then the last point is the bypass of the duodenum and the proximal jejunum. So don't forget all of those very important carriers to take up iron, calcium, and folate are only present in the duodenum and that jejunum. The rest of the small bowel doesn't have those very highly selective transporters that can take those minerals and trace elements up, so you have to follow that. And the best way to follow bone is clearly a bone density study, but if you really want to know if you absorb calcium well, the urine is the barometer. In other words, if we're not getting enough calcium from our diet, we automatically shut off excretion of calcium in the urine, So if you get a 24-hour urine calcium, you're going to know. If it's normal, it means you're absorbing enough calcium. If it's low, it means you're not, and eventually your bone is going to go and you're going to get osteoporosis. So doctors need to be aware of this and to monitor you properly. So what to expect? It's a variable response to loss of a stomach. So some people lose very little weight and do very well and have almost no dumping syndrome. Some people have horrible dumping syndrome and get into trouble losing a lot of weight and get into big-time nutritional problems. So we don't know who you're going to be, and that's why there's no point in, saying you're going to be the worst or the best case scenario. We can't. That's a hard thing to predict. But certainly the dumping syndrome is the most bothersome. Yes, feeling full very quickly after you eat is unpleasant, but that dumping syndrome really makes people, just stops them in their tracks. They can't function, they feel dizzy, they feel terrible. And the diarrhea is not to be underestimated. So sometimes the weight loss is not because you're not eating enough. If you have dumping, the food goes through you so fast, the small bowel can't even pull the nutrients in, and some of the highest malabsorption occurs in people with severe dumping, and they lose weight very quickly and they become dehydrated. So that can be a very dangerous thing as well if you have bad diarrhea with it. So most initially lose weight. So we have to retrain people to eat differently. It's hard. Children retrain very quickly because they're small and they can be easily trained to do whatever you want them to do, actually, early on. And children who don't eat, you have a hard time making them eat if they don't start eating at, early onset when they're born. So the same is true. For the adults, it's the hardest. They have very strong habits of how they eat, and they have to completely change those habits. So you have to give yourself some leeway. You have to not be hard on yourself and say, I'm doing this to myself if I only ate different. Just, again, stay calm and keep in your mind the physiology of how it's working now and how to best make it work for you. And most regain weight. In fact, some people over time, unfortunately, even if you start out really obese and lose your stomach and lose weight, over time, people will regain that weight, sometimes to the same obese weight over time. Time means years, not weeks. So most people do regain toward their baseline. Whether they get there or not fully is, again, a variable. And then there's a lifelong monitoring that must go on. So you must not let your doctor say you're fine now, your weight's fine. Weight is one part of it, but the vitamins and minerals is a very big part of it, and that's important for bone health and for blood, to make enough blood cells, and for your nervous system, B12 in particular. So you have to pay attention to that. I guess that was my last slide. Okay, so questions. Yes, so ferritin is, you mean in terms of what happens to your ferritin level?
Yeah, what happens to your ferritin level and ferritin supplements post-COVID?
So ferritin is sort of an indicator of not getting enough iron in the body. So how it works is if you don't get enough iron, your ferritin falls, and then eventually you become anemic and your cells become very small and you become anemic. So the ferritin is the first indicator that there's not enough iron. It's like urine calcium. It tells you you're not absorbing enough calcium. Ferritin tells you you're not getting enough iron in. So ferritin level can be useful to tell you that. How to push more iron in. The iron is the one thing our body cannot excrete, so our body is very cautious about how much iron it lets in. But in the gastric bypass situation, it's even more complicated because the iron's not even getting there for the duodenum to take it up the way it normally would.
Are you encouraging separate ferritin testing for post-COVID gastrectomy patients?
Usually I go by blood count, and when I see it's the MCV or the cell size start to fall, then I pay attention. Men are different than women. For men, it will be an accurate read. For women who have premenopausal women, they sometimes run low irons, ferritins for a different reason. So, you know, I wouldn't say would be a bad thing to check it once a year. Would I check it every month? No. Would I check it intermittently? I tend to check the blood count, because if the blood count is good, you're getting enough iron. And to try to push iron in with oral tabs is difficult and causes some symptoms in its own right. So I don't try to push it unless I see some evidence that it's affecting the blood count.
And what about absorption of oral medications?
Oral medication, that's tricky. You can look up where medications get absorbed. There's two factors. One is how fast the medication runs through you, and the second is, can it be absorbed in the small bowel? Most medicines can be absorbed in the small bowel, but again, if you really need to have a certain effect of a medicine, then we try to pick medicines that you can measure blood level on. So that can be very helpful if we can measure blood levels. But you've got all of your we've got way more intestine than we need to absorb enough, 10 to 20 feet. So we bypass just, 40 centimeters or so of that. So really, the absorption is quite good through most of the small bowel, except for those select vitamins, the minerals and vitamins I showed you. Those only can be taken up high.
Along those lines, and this can be made available to the larger group, a pharmacist who is a patient herself has put together a handbook of medications post-gastrectomy. So
That's very useful.
I don't know if that's already publicly available, but we can certainly make it publicly available.
So that
I'll
is
ask her.
very helpful. But sometimes you can look up you can look up a drug and they'll usually say where it gets absorbed. If it gets absorbed only in the stomach, that's going to be a problem for you. If it can be absorbed in the stomach and the small bowel, then you'll be probably okay.
We'll take one more question. Dr. Summerad's going to be around as well, but go ahead.
I was just wondering, as far as like just calorie and fat and protein absorption, like say I bring in 3,500 calories.
Yeah.
Is my body actually absorbing those, or is it more like 75%? Or I'm just curious, because I feel like there's days where I bring in a lot more calories than I feel my body shows sometimes.
So the second part I didn't talk about was mixing. So remember I showed you that physiology slide where that very concentrated bile, pancreatic juice, and little squirts of food come in so it can be really super digested and the most effectively absorbed. So you've got somewhat of a mixing problem, which means where the enzymes in the bile and the food come down at that limb, and then it's moving downward, so you don't, and it's coming in bigger amounts. So you're not going to be as efficient, but so you may have to eat more calories to keep the same weight, but ultimately, in terms of essential fatty acids and amino acids and the overall status of weight and nutrient status in terms of those kind of deficiencies, we don't see it much in fact, I've never seen it unless you have severe dumping. Then I've seen people become deficient in fatty acids and amino acids and protein. But otherwise, I don't see it that often. And most dumping can be controlled once people understand the kind of diet they need to take. Virtually everyone gets better who comes to me and didn't quite understand what the dumping is and how to work with it. Virtually everyone gets better. There's a few really tough cases, but most are pretty good.
Great. Thank you so much, Dr. Summerad. That was great. I think you can see why she's one of our best teachers here and in the nation here. So our next talk is going to be Dr. Setia, who is someone and the type of professional that you may not encounter, although she has said she is happy to see anyone who would like to see her. She is our pathologist. She is a board-certified pathologist who specializes in the GI tract, and she is the one, once that gastrectomy specimen comes to her, it spends a lot of time looking through that to give a very accurate information about what is going on and whether there are these areas of cancer. So with that, Dr. Setia, thanks.
Thanks, Dr. Cooper. And everyone can hear me in the back? Okay. And thank you, everyone, for giving me a chance to talk about my favorite topic and sharing the pathology aspects of it with you. Just as a disclaimer, the talk is very visual, but I really think the pictures are way prettier. So, okay. So with that, let's just begin. So let's begin with a few basics about HTGC, or hereditary diffuse gastric cancer, and I'll be using the term HTGC just because the other is it's a mouthful. And the first question that comes to mind is what causes HTGC? And I know we've touched on this several times today, so I'm just quickly going to recap this for you. So in individuals or people who do not have hereditary HTGC or cancer, their stomach cells or the rest of the cells in the body, they have 2 functional copies of CDH1 gene. But if you have HTGC, even the normal stomach cells have only 1 functional copy of CDH1 gene. And over time, this functional copy is also lost, and that's when the normal cells will turn into cancer cells or signet ring cells. And we'll come to why we're using this term signet ring cells instead of cancer cells. At this point, the cancer is at a very early stage. Now, if these signet ring cells are left in the body, they're going to acquire more mutations, and that's when the cancer turns into an advanced cancer. So how does HTGC cancer differ from other types of gastric cancer? And to understand that, we are going to take a look at a few pictures of stomach. For these, the stomach has been cut open and laid flat, and I'm just going to explain what we did so that it becomes easier when you're looking at the image. This is just a brown bag, which I think is kind of like a stomach. So what we did was we cut it from the side. So if this is the in and out of the stomach, we just cut it from the side and we opened it. So, sorry, it's like this. We opened it, and what you're seeing in the images is the inner lining or the mucosa. And why the inner lining is most important is because this is where the cancer comes from. So next few images are going to be gross images, or gross meaning we are not using a microscope, of stomach. So this stomach is from an individual from an autopsy case who does not have any concern for gastric cancer. So you're looking at the inner lining, and what you can see is the stomach has folds, as we saw earlier in the endoscopy pictures. And this is normal stomach. This is what it's supposed to be. Folds are good. This is an HTGC stomach, and this also has folds. So that looks pretty good too. And this is a stomach from other types of gastric cancer. And as you can see, it looks very different. It has this one big tumor here, another big tumor here. The folds are kind of gone. Where they are present, they look very thickened and abnormal. So what I'm trying to say is if we compare the 3 stomachs, the HTGC stomach looks more like no cancer or normal stomach versus the other type of gastric cancers, which look very obvious just by looking at the stomach without using a microscope. Now, for this image, what we did is we cut the stomach into strips, and we are looking at it at the edge. So this here, the purple zone, is the lining. And of course, it has been stained with pink and purple dyes. So the purple zone here is the lining, which is that important zone from where the cancer arises. And the pink is the supporting wall. And this stomach has been magnified 20 times. So this is normal stomach with a purple zone and pink wall. Now let's look at HTGC stomach, again magnified 20 times, and we see the purple zone and the pink wall, versus the other type of gastric cancer where the purple and pink is all messed up now. The purple is invading the pink. So if we compare the 3 images again, we can say that the HTGC stomach looks almost like no cancer stomach and very distinct from other types of gastric cancer, even when magnified 20 times. Now let's zoom in a little bit further, and now we are going to magnify it 200 times. And now in the purple zone, so we are now only in the purple zone, magnified 200 times. And what we see are these arrows are marking the tumor cells, and you can see there are so many of them. There are so many that it's impossible to even count. I got tired of marking the arrows. So what I'm trying to get to is that the cancer cells are present. They're always present, just that you need high power magnification to be able to visualize them. They're not piling up on each other, so they're not forming tumors like the other type of gastric cancers, so that you can see them as visible lesions. They're not even causing any reaction in the surrounding cells, which means that you're likely not going to have any symptoms. But they're sitting here. They're sitting here. They're waiting to acquire more mutations so they can ambush the rest of the wall, but just that they are there. And I think we've touched on this several times today, but we are basically left with no other option than removing the stomach at this time. And the number of biopsies, and I think, we were talking about 85 as a standardized procedure, but then just studies have come up with a number where you are definitely, or at least 90% chance of finding a biopsy focus. From one person, the number of biopsies that are required is 3,500. That even the standardized procedure or surveillance protocol is probably not going to work. So after that, now let's talk about the path report. So from a very practical standpoint, the stomach comes in to the path department and the path report comes out of the path department. And it's a complex process, and we'll just talk about this process. So the first stop for the stomach is the gross room. And it's actually not gross, it's actually, the people are very helpful and lovely, and you can, make that assessment from the picture here. So what they do is the first step is called accessioning. And by accessioning is what we mean is we are linking the stomach to your information, like the name, gender, and we put it in the computer. So from now onwards, nobody's handwriting, it's all barcoded. So the stomach gets barcoded and gets linked in with the medical records and our pathology system, and that process is called accessioning. Our accessioners are very careful. They double check, triple check. If there is any question, they would call the OR, have the nurse come down. They will make sure that everything that is entered is very accurate. After accessioning, the stomach is handed over to a person who is specifically trained in examining the stomach. This part is called gross examination. So what they're going to do is they're going to open the stomach and they're going to take a look at it without using a microscope and make a note of all the observations, anything that they are seeing. And at this point, they will take sections for microscopic examination. Typically, what we do is we only take sections of the abnormal areas and a few of the background. But as we talked about, this HGC stomach looks normal. So basically, we are left with no other option than submitting the entire stomach. So the entire stomach is cut up into strips, and those strips are cut up into smaller strips and then put in cassettes. And these cassettes will then be processed for looking under the microscope. I must say that a lot of places who do these HGC surgeries do not submit the entire stomach. And that's kind of unfortunate because, you would think, how would they know which sections to put in? They really don't. They're just taking random sections, and as soon as they find one focus of cancer, they stop. It's because of the cost-benefit rate analysis. They think that it's better to just find one focus and stop. But here at UFC, we submit the entire stomach irrespective of the cost. After the sections, the strips are put in cassettes. They go through several chemicals so that they can be embedded in wax blocks. Now, these wax blocks can now, they allow the tissue to be cut into very thin slices so that they can be put on the slides and then stained with the pink-purple dyes so that we can look at it under the microscope. And that's when the slides come to the pathologist, and then we will look at it very carefully and examine the tissue and come up with or generate the pathology report. As I spoke about earlier, the cancer cells, I was referring to them as signet ring cells. This is because they really look like signet ring. So this is a cancer cell, just like blown up at a very high magnification, and that's a signet ring. So they really look like signet rings. And the path report takes a couple of weeks in contrast to a couple of days for a routine case, because this is the amount of work that goes in HGC case versus this is the amount of work that goes in routine case. So please bear with us. It just takes longer just because the whole process is longer. Now let's try to understand the path report. So the most important piece of information that you can get from the path report is T, N, and M stage. where the T stands for how deeply the tumor has penetrated. Is it still in the purple zone? Has it gone down in the pink wall? How deeply has it gone down in the pink wall? N stands for the nodal stage, which Dr. Rogan was referring to earlier, where basically lymph nodes are present all throughout our body, and they are also present around the stomach. So the nodal stage basically refers to, or like gives an estimate of how many of these nodes are involved by cancer. An M stage or metastatic stage refers to the locations involved by tumor other than the stomach and the lymph nodes. And finally, all the T, N, and M are put together and a clinical stage is generated. For HTGC stomachs, mostly the tumor cells are in T1, and then nodal stage is N0. The green is the good side for cancer, and red is the bad side for cancer. So for all the HTGC cases, we are on the good side at the lowest possible stage for cancer. And this is what the pathology report looks like. So it's a combination of all the data, all the things that I've talked about, and you must be, or some of you must have seen this report. The accessioning information is here, and it just states the details, name, gender, date of birth, all the things that we put in at the time of accessioning. This is the final pathology diagnosis. It talks about the signaturing cells, the location, size, and margins. And then this is a T, N, and M stage put over there towards the end. And the gross examination of what the person who first looked at the stomach is listed towards the end. So this is how the workflow starts from the stomach coming in or being received to the report being generated. We do one additional safety step, and Dr. Rogan referred to that earlier, is we kind of make sure that there is no stomach mucosa left in the body, because any mucosa that is left, stomach mucosa left in the body, has the potential to turn to cancer. So to deal with that, what Dr. Rogan would do is what he thinks is like going to be the final place, a final margin or tissue that is left in the body. He'll take a sample of it and send it to us. And we would freeze it rapidly. This is not that 2-week process. We would do it in like 20 minutes. And this is while the operation is still going on, and say that, yes, there's no stomach mucosa, so that we are confident that we are not, wherever possible, that we are not leaving any stomach mucosa in the body. And then, of course, a lot of new things are happening as we are examining the stomach more. We are learning more about disease, and Jessica referred to the new genes, and Dr. Kufer mentioned about the new genes earlier. But then there are still so many questions that we need to answer, and we've touched on them, several times during this session. Like, how long does it take for those signaturing cells to transform to cancer? That can really affect the timing of the surgery. What mutations actually turn? We know about CDH1 and new other genes, but we really don't know what turns the signaturing cells into the advanced cancer. And then, as we were talking about, more sensitive methods that can potentially see those signaturing cells, because they're still in the superficial layer, they really haven't penetrated the wall, so can these be taken care of just endoscopically? It seems like we are very far from it right now, but if there are engineers in this audience, they could really work with us, and then maybe we will come up with better solutions. So in the meanwhile, the stomachs are embedded in wax blocks, and they are in the archives of Department of Pathology at University of Chicago, and you're welcome anytime. They stay there forever. We never discard them. So you can come and take a look at your slides if you want to. So. And then, yes.
Do we have any questions for Dr. Setia?
I was just wondering, that graph you had, is there any way you could bring that back up?
Sure. Let's see. You can tell me which one. Oh, the staging? Oh, okay.
The grid.
I wanted to take a picture of it.
Oh, sure, sure.
That one, thank you.
Like the paparazzi. No?
Yes. Yes,
Do you
sorry.
have a question up there, yeah?
Yeah?
Well, now that you've met Dr. Setia, I'm sure more people will want to come and look at their stomachs with you.
And you're welcome, seriously. I mean, it really, we put in so much time and effort on these cases. I almost feel like I know each person individually. You come in my dreams with ideas that I should work on, so it'll be good to put a face to it.
Wonderful. Thanks so much. All right, and right before lunch, we have our last speaker, but certainly not our least speaker. This is Dr. Deepa Sheth. She is a radiologist, and she's going to talk about something that I think we don't always focus on because it affects only 50% of our patients, but really a very important part of managing HDGC. Hopefully we'll at some point get that the name changed, because I think the lobular breast cancer, and for women to know what is the optimal surveillance and or surgery is critically important. And Dr. Sheth is really at the cutting edge of new technologies. That's kind of a theme that's coming out here, and how we can apply that to better identify breast cancers earlier. So with that, let me see where yours is, right here. What's that? Okay. All right, and Dr. Sheth, thank you.
All right, well, thank you for having me here today. My name's Deepa Sheth. I'm a breast radiologist, and pretty much all I live and breathe is breast cancer, starting from the screening to the detection and the diagnosis of it. I know I'm the only one standing here between you guys and lunch, so we'll try to be quick and speedy through this, but we'll capture some important points, okay? So just like in yoga class, we want to set our intention for today's session, right? So we're going to recognize the clinical presentation of invasive lobular cancer. We're going to try to understand the relationship between invasive lobular cancer and this hereditary diffuse gastric cancer. We'll talk about the importance of imaging in HDGC as it relates to ILC. And then, just in terms of like better understanding breast cancer screening to improve overall breast health for all females, whether you are affected by HDGC or not, okay? So first is anatomy. I want you guys to understand what makes up a breast, right? So the basic functional unit of a breast is something called a lobe. And within that lobe, I want you to sort of imagine a big tree, a huge tree with tons of big branches. And those big branches sort of break off into smaller branches and even smaller branches. And at the end of that small branch is a cluster of grapes, okay? So let's start with the cluster of grapes. This cluster of grapes is called acini, or the lobules. And these are these little grape-like structures right here, which you can see with the pointers. And we have 100 acini per lobe, okay? Then this cluster of grapes comes to a little branch called a terminal duct, and then it comes into a larger duct, and then it comes to the main duct. We have about 15 to 20 main ducts, and then they all empty out into the nipple. So together, this creates the functional unit of a breast. Here's some pretty pictures that Dr. Setia sees all the time, I'm sure. This is a cross-sectional image of a normal breast tissue. And you can see this long structures right here are the ducts or the branches of the tree. And then these smaller little circles right here are the grapes at the end of that tree. And like I said, together, the grapes, which is the lobules, and the long structure, the duct, makes up the functional unit of a breast. And then here's just some nice 3D histology images, nicely showing that branch that we talked about, and then the cluster of grapes or the lobules. And here's just another zoomed in view of these grapes or the lobules. Okay, so why do we get worked up about that? So let's talk about invasive lobular cancer and sort of the origin of that name, right? So invasive essentially means that you have cancer that's invaded or spread to the surrounding breast tissues. So it's no longer contained within this grape-like structure or the lobule, it's come outside of that, so it's invading. And then the term lobular means that it starts in the lobules or the grapes of the breast. So invasive lobular cancer starts in these little grape-like structures that we talked about, and it's invaded outside of that. So ILC is the second most common type of breast cancer. The most common type is invasive ductal cancer, and ductal cancer starts in the ducts or the branches of the tree. So ILC starts in the lobules or the grapes, and it composes about 10 to 15% of all breast cancers. Compared to IDC, it tends to occur later in life. So IDC, we say, starts in the late 50s, early 60s. ILC tends to occur in the late 60s, early 70s. And also, ILC can spread to lymph nodes and possibly to other parts of the body, which we'll talk about. So what are the signs and symptoms of breast cancer? So I try to use sort of lemons to help you portray the different ways that breast cancer can present. And as you can see, there are lots of different ways. There's no one classic symptom for breast cancer, right? So you can either have a feeling of a thickened area of your breast, you can have a dimpling of your breast, crusting of the nipple, sort of changes in the skin, as in like red or heat, unexpected fluid coming out of the nipple. You can even have new bumps or lumps or a sunken nipple. But for ILC, there are some very specific signs that you need to look out for. So for ILC, the most common presentation is either a thickening of the area, a dimpling of your skin, or a change in your nipple appearance, right? So either it's kind of pulled back, retracted, or sunken. Now contrast that to invasive ductal cancer, which is the most common type of cancer, that presents as a lump, like a discrete bump or a lump in the breast that you can feel. So when you look at ILC, really at the very earliest stages of ILC, there's really no signs or symptoms. It's a very subtle cancer, right? And really when the patient first feels anything abnormal, it's just a thickening or a vague hardening of the skin. You're like, I'm not sure, my nipple's starting to look a little different. It's falling differently on my breast. And it can be really hard for a radiologist to see this on the mammogram compared to IDC, which is like a mass or a lump, okay? And so let's talk about invasive lobular cancer, kind of in the algorithm of breast cancer screening, right? So what do we, starting with the screening mammogram all the way to the very end of this diagnosis, let's kind of go through this journey together, right? And what it means to go through breast cancer screening. So at the very beginning, either you have a symptom and you tell your doctor, or you have no symptoms, right? So patients that have no symptoms should start with a screening mammogram at the age of 40 if they're at average risk for breast cancer. If they're at elevated risk for breast cancer, which means they may have a genetic mutation like CDH1, and we'll talk about that, you should start earlier screening. Contrast that to if you do have a symptom, then you should tell your doctor, okay? But the bottom line is you're gonna come see us in the Breast Cancer Imaging Center, and you're gonna get a mammogram. So this is the actual room where you're gonna get your mammogram. And on the right-hand side of the screen, you can see the mammographic unit. Your breast is going to be between this black grid right here and this clear plastic paddle, okay? And your breast will be held in between here, held in gentle compression. The point of the compression is to A, hold your breast in place while you're breathing so it's not moving, and B, it actually reduces the radiation dose to the breast and we decrease the thickness of the breast tissue. So it's actually for you when we compress that breast, okay? And then the technologist is gonna be standing behind this lead shield taking the images after she finishes positioning you. For a regular screening mammogram, we take 2 images per breast tissue, and it's in 2 different positions to help us triangulate lesions and see tissue in 2 different planes or dimensions. Once the technologist acquires these images, then the radiologist, myself, will be in the clinic taking a look at your images. If we see anything abnormal at this time on the mammogram, we may request additional images just to see whether this is something that truly persists or it's something that sort of goes away and it was just your normal glandular tissue. If I see something that does persist, then I may ask for an ultrasound examination. Okay, so this is a mammogram right here. We have the right side and the left side. This is one view of each breast. Any guesses? Is it abnormal, not abnormal? What side's abnormal? Hard to say. Hard to say. Okay, I'm gonna tell you it's the left side. But the key here is I'm gonna show you the same patient's mammogram 1 year ago. So this is 2018 on the left-hand side and 2019 on the right-hand side. It's subtle, but I want you to look at this area. Can you see a faint developing asymmetry? It's like faintly whiter, right? There's slightly more white tissue or glandular tissue that's developed there, right? And let's look at another plane of view. So on the left-hand side, we have the year before, and the right-hand side, we have the current one. And again, faint. Right? You can see this really slow developing asymmetry that really you may not have caught without her prior mammograms. And it's subtle. It's very similar to HGGC, right? It's like infiltrative. In addition, take a look. Here you can see there's skin retraction. The skin is pulled back. The technologist, it's not a skin fold. The technologist just couldn't straighten it out because the tumor is sort of tugging on that skin. And there's a little bit of skin thickening here too. Can you see that band of skin is a little thicker right there? And that contributes to the nipple retraction and the sort of positioning of that nipple different from the other side, right? So this is the classic findings of ILC on a mammogram, really subtle. So once I see something like this on a mammogram, I'm going to ask to put you into ultrasound. Ultrasound is a different imaging modality. It gives me more information, whether something is solid, whether something is filled with fluid. It just helps me kind of paint the entire picture of what's going on with you. So this is the ultrasound room. Here at the University of Chicago, we do our own ultrasounds. We don't have a technologist doing it, so I will be in the room and I'll introduce myself to you, sort of talk you through what the findings are on the mammogram and what we're going to do here with ultrasound, okay? So I'm going to zone in with my ultrasound probe, and I will do a targeted ultrasound evaluation. These are pictures of ultrasounds. And so if you can see with both of them, the top of the image is your skin. It's a thin, bright white line. These little gray ovals or clouds are adipose tissue or fatty tissue. And then this gray sort of structure here is your invasive cancer. Now, contrast this to ductal. So ductal would look like a nice big black circle. It would be very discrete. I could draw a pencil around it. With lobular, I really can't draw a pencil, right? It's super fine, discrete, there's spiculations, it's sort of infiltrating through the parenchyma, and oftentimes your ultrasound will underestimate the true extent of disease on the mammogram. We just can't capture all of these fine infiltrative areas percolating through your breast tissue. But it's definitely there, and you can definitely appreciate that it looks different than the surrounding adipose tissue. So once I see this area, and I sort of talk to you about my findings, I'm going to recommend a biopsy, because it definitely looks suspicious, right? And we need to get now actual tissue samples to get pathologic proof of this. And so we'll have you return normally at University of Chicago on a separate day, and we'll sort of repeat the ultrasound examination, and then we'll go ahead and take a few samples and sort of get a biopsy, okay? A biopsy traditionally for the breast takes about 15 minutes, 20 minutes, but the whole procedure really with setting you up, getting you prepped, cleaned, ready, takes about 30 minutes. It's a same-day procedure. You can go on with your regular day at the end of that. There's no real stitches, no sutures, no staples. You just walk home with a Band-Aid and a pressure dressing over it, okay? The pathology results usually take about 3 to 4 business days. Our path folks are pretty fast about that. And they're going to look at this under the microscope, okay? So, as has been the theme with hereditary diffuse gastric cancer, lobular is also characterized with this CDH1 mutation, right? And so like we've talked about earlier, it has this gene that controls how cells sort of adhese or stick to each other. And there's loss of that. And so you can see with this lobular cancer, it's what we call the single file spread. It's these lines of cancer that are singular like this. And you can appreciate on the mammogram, it's subtle, right? It's spider-like. You can appreciate on the ultrasound, it's subtle, spider-like, percolating through the tissues. Very similar concept, parallel to what happens in the stomach, also happens in the breast, and it has to do with the CDH1. So staging, we've kind of touched on that already now, luckily, and so essentially it's this process to figure out how far this ILC could have possibly spread from outside of your breast, outside of these lobules, right? And so as has been mentioned, we really want 3 pieces of information to put together your stage, and it's this T and M, right? So T for tumor, N for nodes, and M for metastases to other parts of your body. And we use different combinations of imaging just depending on what you have to help us figure out your stage. And so really the most common ones may start with an MRI of your breast. And MRI is really the most sensitive exam we have. Of all the imaging tools that we have in breast imaging, that's the most powerful tool that we have. It picks up to 90% of all cancers in terms of sensitivity. And you can see that this is our same patient that we've been looking at with mammogram and ultrasound. And I want you to look at her left side, the side that we've been focusing on, and you can see all this white tissue. It's pretty sort of spider-like and diffuse, kind of going through the entire breast. And you can appreciate that ultrasound and mammogram may have underestimated it, but MRI does not. It tells you the exact extent. And interestingly enough, with this patient, she actually had another area on the right side. And we ended up biopsying that was also ILC. So she had ILC in both of her breasts. The other type of exam that you may get for staging is something called a PET scan, along with the CT, and this uses a different type of radioactive tracer to help detect different types of tumor activity, right? So MRI uses gadolinium, which is a contrast agent that we inject into your veins to help us detect areas of enhancement in your breast. PET scans inject FDG, which is a radioactive tracer attached to a sugar molecule. So we're trying to find things that eat up a lot of sugar, are very metabolically active, essentially. And so a PET scan is often combined with a CT scan, so we get 3D localization, and we can figure out, oh, this is hot. Well, let's look at the CT and see where it's hot. Is it in a rib? Is it a muscle? Is it an organ? And then we also can get bone scans too. And so bone scans are radioactive tracers attached to bone molecules, right? And so it really goes to places where lots of bone turnover and uptake is occurring, sort of like in a metastases in bone spread. Okay, so ILC has a very unconventional or unusual spread to different parts of the body. In this diagram, you can see the black arrows are where normal ductal cancer goes. The most common type of breast cancer usually goes to the liver and the brain. Contrast that to lobular cancer, what we are talking about, it goes to the red dots. And you can see it's slightly different, right? It goes to the bones, it can go to the ovaries, it can go to the GI tract, it can go to the abdominal lining. It sort of goes to these serosal surfaces. And the thought process of this different metastatic spread, we think, is due to the hormonal production, right? So it has an association with exposure to hormone therapy, and perhaps it goes to ovaries because there's hormone production there. And like I mentioned earlier, it tends to have a late recurrence, so a late onset and late recurrence. And so for radiologists, oftentimes patients will come and say, this is our 5-year anniversary, we're clear. And we want to just say, well, actually, it can recur between the 5 to 10 years after you're cleared, right, from surgery. So we want to be especially careful looking at your mammogram 5 to 10 years after you're cleared, just to make sure that there's no recurrence. Okay, so now let's talk about risk factors. And the 3 main ones for ILC are age, something called LCIS, which is lobular carcinoma in situ, and the theme of our day today, inherited genetic cancer syndromes, right? So let's first focus globally on age. We know that as you age in life, your risk of breast cancer goes up, right? So the older you get, the older your risk of breast cancer. Like we mentioned with invasive ductal cancer, which is the most common type of breast cancer, it happens in the late 50s, early 60s. You contrast that to ILC, lobular cancer, which is what we're talking about, it's later, okay? Then the other risk factor is something called LCIS, or lobular carcinoma in situ. It's actually a bit of a misnomer because it's not cancer. It has that in the word, in its title, and that's something that I know pathologists are working to change perhaps, but it's not cancer. What it is just a proliferation of these abnormal cells that are confined within the lobules, within the grapes that we've been talking about, and it hasn't invaded or broken out of that. LCIS is important, so if you've ever had a benign breast biopsy, your surgeon or your radiologist may say, oh, it's totally benign, no worries. But if you ever look at that pathology report and it ever says LCIS on it, you want to sort of be careful because that's actually a marker for increased breast cancer, okay? So simply having LCIS on a pathology for a benign breast biopsy can increase your lifetime risk from 12%, which is the average lifetime risk for females, to 30 to 40%. And just by having LCIS doesn't mean that you're necessarily going to get ILC next year. You could get ILC or IDC. You could get it on the same breast. You can get it on the opposite breast. It's just a risk factor, okay, for something proliferative. And oftentimes you can have LCIS bilaterally, and it really just increases your risk. So it's something for you guys to be aware of. And then, of course, we've been talking all day about this inherited genetic cancer syndromes. And so now we know that patients with this hereditary diffuse gastric cancer actually have an increased risk of ILC. And it has to do with the CDH1 mutation that we've been talking about. So both cancers, both in the stomach and the breast, are associated with this sort of diffuse infiltrative type pattern, right? You can see it on the mammogram, you can see it on the ultrasound, on the MRI, and it's not a discrete mass, and it doesn't present as a discrete mass. It presents as a thickening or sort of change in positioning of your nipple. And like we talked about, patients with the CDH1 gene mutation have an elevated lifetime risk of developing ILC, and it can be up to 40 to 50%. Okay, so imaging guidelines. So how do we determine who gets what and when? Well, that's the big question these days, right? It's a hot topic in breast imaging. Should I get it at 40? Should I get it at 50? Every year, every 2 years? And there's this push from radiologists and the community in general to sort of come up with a more personalized approach. Instead of doing this one-size-fits-all for everyone, that all of you should get it at 40 or all of you should get it at 50, we want to personalize it. And a few of the ways that we can personalize it for each of you females in this room is by looking at 2 things. One, we're going to look at your breast density, and one, I'm going to look at your lifetime risk of breast cancer, okay? So let's talk about these 2 things. So what is breast density? So that is a term created by radiologists, and it's essentially the proportion of the black tissue, which is the adipose tissue, to the white tissue, which is your glandular tissue, okay? So we break it up into 4 categories. It goes from fatty to scattered to heterogeneously dense to extremely dense, so low to high. And you can see that as we progress through the quartiles, it gets whiter and whiter and whiter, right? This means there's more and more glandular tissue compared to adipose tissue. And so the patients that have heterogeneously and extremely dense breasts have really dense breast tissue. Why do we care about that? So there are two main reasons why breast density has become really important. First of all, you can imagine if breast cancer looks white, like I showed you earlier, and your breast looks white, it can be really hard for me as a radiologist to see what's normal and what's not, right? So there's something called a masking effect, where my sensitivity as a radiologist decreases as your breast density goes up and up. In addition, patients that have extremely dense breast tissues have an inherently increased risk of breast cancer. Having more tissue means you have a greater risk of breast cancer. So just having this category D, dense breasts, can lead to a 4 to 6-fold increased risk of breast cancer. In addition, it's become a national issue, right? So if you go to densebreastinfo.org, you're going to see a map that looks like this. And there's now 37 states in the United States that require dense breast notification laws to females. Illinois is one of them, right? So if you click on Illinois, it's going to pop up a window that looks like this. And just sort of scooting down to the insurance tab, it says, if a routine mammogram reveals heterogeneous or extremely dense breast tissue, coverage must provide for an ultrasound screening and an MRI, right? So now, instead of just talking about dense breast tissue for females and saying, oh, it's bad, or it's a risk factor, now there's actual guidelines, imaging guidelines that have stemmed from that. And it's going to become a totally nationwide thing. The FDA just proposed last week of March that they want every state to have some sort of dense breast notification and some sort of dense breast recommendation, right? It's one thing for us to notify you, but we also want to have a recommendation for what you should do for that, okay? So I want everyone to go home, all the females, and take a look at your mammogram reports if you've had one, and take a look at your breast density. If it says category C or D, or has the word dense in it, that means you have dense breast tissues, and there's additional options for you as a female for screening. So if you go home and you look at your mammogram report and you actually say fatty or scattered, it doesn't have the word dense in it, you can just start getting mammograms every year at the age of 40, annual. However, if you go home and it does have the word dense in it, has heterogeneously dense or extremely dense breast tissue, we can offer additional screening guidelines, right? And so you're gonna say, well, why does that matter? Remember, we talked about two reasons for dense breast tissues. There's masking effect, it makes it hard for me to see your cancer, and B, you have an inherently increased risk of breast cancer with the breast density. So for patients like this, we offer something called a 3D mammogram, or tomosynthesis. This is going to be the next evolution of screening mammograms. At the University of Chicago, end of June, we're going to have only tomosynthesis units, so that's it. So every patient that comes in for any type of mammogram is going to get tomosynthesis. And it's pretty much just going to take over and replace the regular 2D mammogram. So what this is the mammogram unit looks almost the same as the tomosynthesis. However, the difference is that this X-ray tube actually arcs, and it takes pictures from a plus and minus 15 degree. So instead of just taking the simple 2 images of each breast that we talked about, it takes slices through the breast, kind of like a CT scan. And then us as a radiologist can scroll through your breast tissue, penetrate through that breast density, and find anything that may be hiding underneath it. So, examples. What side looks abnormal, right or left? Is she dense? She's dense, right? So for her, we would have probably recommended getting a tomosynthesis, and all of you guys said right. However, I'm going to show you what tomosynthesis looks like. Can you see how we're scrolling through the breast tissue right now, right? So we're going from one side of her breast to the other. These are 1 millimeter slices, and radiologist looks at every single one of these slices for every breast, for every patient, so you can imagine how many slices we're looking through at one day. And the nice thing about this tomosynthesis is that when you go to that exact slice, you can see this beautiful cancer, right? With the amazing spiculations kind of percolating through this tissue, pushing the native tissue away from it, right? It's got these spicules coming out. This is classic for lobular, this kind of spiculated, distorted look. And it's best seen on the tomosynthesis. And so knowing what the tomosynthesis looks like, we can do an ultrasound evaluation, we can biopsy it, get pathology results, okay? So we talked about breast density. If you have increased breast density, you want to get tomosynthesis. Let's also switch now to lifetime risk of breast cancer. So the average female has about a 12% lifetime risk of breast cancer. Those females, they should stick to the mammogram. Depending on your breast density, you should get tomosynthesis or ask for it. How about if you're an elevated lifetime risk of breast cancer, right? So we have guidelines for this. And if you go to the NCCN guidelines, which is the National Comprehensive Cancer Network, And if you look at their guidelines for patients that have an increased risk of breast cancer, which is about 20%, then in addition to the mammograms, we recommend the annual breast MRIs, right? So patients can oftentimes stagger it, so every 6 months they either get a mammogram or an MRI. And that way, every 6 months a radiologist is sort of looking at your breast in some modality or another. Then if you look at the ACR guidelines, which is the American College of Radiology, it breaks it down to different risks for females. And again, for high-risk females with a greater than 20% lifetime risk of breast cancer, we ask for the MRI, which is green. It's appropriate. There's evidence backing that up. And sort of a plug for a study, which you may see some flyers for, we have launched something called the CAP study, which is called the Chicago Alternate Prevention Study. And so this is geared for patients that have an elevated lifetime risk of breast cancer. This particular study is targeting patients with a greater than 30% lifetime risk, but this is something that you can talk to our team about to see if you're eligible. And what this really does is instead of just doing the annual MRI and the annual mammogram, we're actually going to be trying to do biannual MRIs, so 2 MRIs a year, and we're sort of letting go of the mammogram. Our thoughts are that this MRI, since it is the most sensitive tool that we have, why not use it for the patients that really need it the most? Why not offer these MRIs 2 times a year? Now, you may think, why don't we do that for everyone already? Like, it totally makes sense, right? Well, there's the realistic issue of cost. These MRIs can oftentimes cost $4,000 to $6,000. What we're doing here for this CAP study is we're trying to create a shorter, abbreviated MRI. So I'm able to bring it down to about 5 minutes, and then it only costs $400. And so we're trying to prove that this abbreviated MRI is just as equivalent to a full-length MRI, and perhaps we can make the argument that this should be instituted nationally and bring the cost down for an MRI, and offer it to patients 2 times a year. And so if you guys are interested in this, we actually have an email address. It's pretty easy. It's caps@uchospitals.edu. Shoot us an email. We'll be happy to talk you through it, get you tested if you need to be tested, help answer any questions. That's one of the ways that you can get a hold of me, too, if you have any imaging questions as well for this study. Okay, so conclusions. So we know that ILC is the second most common type of breast cancer. IDC, invasive ductal, is the most common type. As we've mentioned, it can present with thickening or hardening, right? It's not a discrete lump or mass like in ductal, and that has to do with this E-cadherin business that we've been talking about, right? This loss of cell-to-cell adhesion. And so because of that, it sort of infiltrates through the tissue, infiltrates on the mammogram, the ultrasound, and oftentimes we can underestimate the disease because of that nature of it. And in addition, it also has an unconventional metastatic spread of disease. So it doesn't go to the usual sites, it goes to these oddball sites because of its E-cadherin mutation that it has. And it's linked to hereditary diffuse gastric cancer syndrome. And in terms of imaging guidelines, we obviously recommend earlier screening for these patients because they're at high lifetime risk. And so they need to get not only just a mammogram, but an MRI, and they can alternate it every 6 months just to make sure that we're sort of catching you and always keeping a track of you with this intensified surveillance, right? So then we return back to our intentions for today that we started our talk with. So breast cancer screening is a personalized approach, right? There's no one size fits all. There's no one model that's going to match all of you guys. And that's our goal as a radiologist, is we want to talk to you, we want to get to know you, your family history, your personal history, and we want to come up with the right guidelines for you to catch the cancer at the earliest possible stage that we can for you, right? And so general guidelines, like we've talked about, annual mammographic screening starting at the age of 40. If you are high breast density, so take a look at your letters at home. If it has the category C or D or the word dense, you can ask for a 3D mammogram, right? And you can even ask for an MRI if you have dense breast tissue because of these federal notification laws. And if you find out that you're at elevated risk, you have the CDH1 mutation, then come on by. We can do the MRI for you. We can even enroll you in the CAP study if you're eligible, and we can do MRIs twice a year. And you know, we want to sort of tend more towards this concept of preventive oncology, right? Knowledge is power. We want to catch things even before they've started with you, right? And so it's this whole concept of putting everything together with genetics, with consultation with your gastroenterologist, with consultation with your surgeon, with a nutritionist, with your radiologist, right? We want to all be part of this team. And like Dr. Rogan said nicely, right? Like, we are all here because we're super passionate about this. Like, we love what we do, and we want to talk to you guys and help you get through this, right? So UFC is all about this multidisciplinary approach. You've seen physicians from all different departments here today, and it's great. Like, we really love it. And if you guys have any questions, definitely feel free to come up to us. We would love to answer your questions, okay? Thanks.